Good morning, everyone, and welcome. I'm Bob Phillips, co-chair of the National Academies of Sciences, Engineering, and Medicine's Consensus Committee that authored the report Implementing High-Quality Primary Care, Rebuilding the Foundation of Healthcare. My fellow co-chair, Linda McCauley, and 18 other committee members were instrumental in producing this report. This report was unusual in its charge, which included the development of an implementation plan that included a recommendation that the Secretary of the U.S. Department of Health and Human Services develop a Secretary's Council that was designed to coordinate primary care strategy across Health and Human Services agencies. That recommendation led to the formation of the Initiative to Strengthen Primary Health Care within the Office of the Assistant Secretary for Health, which seeks your input over these next 2 days about this federal primary care coordinating function. I would like to thank the National Academies staff and the OASH team of Drs. Judith Steinberg and Shannon McDevitt for the many hours they have dedicated to help plan this webinar. It's been quite remarkable. This webinar includes 2 plenary and 5 panel sessions planned across the next 2 days. Today, we will have 1 plenary and 2 panel sessions. I'm also grateful to Dr. Victor Zhao, President of the National Academy of Medicine, and Admiral Rachel Levine, the Assistant Secretary for Health, for opening our meeting before our first plenary. Dr. Zhao, thank you so much for opening our workshop with your remarks.
Thank you very much, Dr. Phillips. Thank you for leading this really important study, the workshop, and all the things that you do for us. Thank you indeed. So welcome, everyone. I'm Victor Zhao, the President of the National Academy of Medicine. And I'm so pleased to see all of you here. There are over 300 of you for this webinar. This webinar, Strengthening Primary Healthcare, is really important. And I wanted to have a chance to see all of you say hello and to thank the hard work of our staff, the Office of Assistant Secretary of Health, and of course, Bob Phillips and the whole study group and our learned experts. This webinar, as you heard from Dr. Phillips, was developed in collaboration with the Office of Assistant Secretary for Health, the primary care team. You know, it builds on, as you heard, the National Academy's consensus report on implementing high-quality primary care, rebuilding the foundation of health. The title says it all. We have to rebuild the foundation of health. You know, it is actually the first National Academies report focused on primary care in large number of years. Not that we don't care, we always talk about primary care, but 1996, the Institute of Medicine report on primary care, Americans' Health in a New Era, was the last full report. So this is why this report is so important and timely. As you heard from Dr. Phillips, the committee's charge was unusual in that it included development of an implementation plan. And that's why we're meeting today. I would tell you that increasingly the National Academies are looking at not only giving a report, but how to turn recommendations into action, hence an implementation plan. This report was published 10 months ago, but the Office of the Assistant Secretary of Health picked up the committee's recommendation. That is, they should form a Secretary's Primary Care Council. And they, as you heard, created an initiative called Strengthen Primary Healthcare, led by Drs. Judy Steinberg and Shannon McDevitt. So this webinar really to engage many of you, the external stakeholders, to inform their work, our work in shaping a proposal to Secretary, how HHS can organize primary care strategies for addressing nation's pressing healthcare problems. So it's a very exciting point because it's the opportunity for you to help with a great organization of the organization committee to discuss and inform the Office of Assistant Secretary of Health. You know, we at National Academies always aim to strengthen scientific, engineering, and medical fields and their capacity to contribute to human welfare. I think that today's webinar is an example of our effort. So thank you very much for being here. Thank you, Bob, for allowing me to say a few words of welcome. I really want to do this because it's so important. And of course, I look forward to hearing Secretary Levine's comments as well she too plays such an important role in this area. Thank you.
Dr. Zhao, thank you so much for those comments and for helping frame what we're trying to achieve these next 2 days. Reflecting that partnership, our next speaker is Dr. and Admiral Rachel Levine, who is the Assistant Secretary for Health. She is unable to join us in person today, but has pre-recorded welcome remarks for us. But know that other members of the Office of the Assistant Secretary will be with us the next 2 days. So if staff could play the recording of Admiral Levine.
Welcome, everyone, to the National Academies of Science, Engineering, and Medicine webinar on strengthening primary health care, which was developed in collaboration with my office, the Office of the Assistant Secretary for Health. Thank you, Dr. Zhao and NASEM, for supporting the effort to strengthen primary health care by first publishing the NASEM report, Implementing High-Quality Primary Care, Rebuilding the Foundation of Healthcare, and with your efforts to implement the report's recommended plan. This includes hosting the webinars today and tomorrow. And thank you to our speakers and audience members for sharing your perspectives and innovations and engaging in a dialogue to strengthen primary health care. The Biden-Harris administration and the United States Department of Health and Human Services aim to improve access to health care and health outcomes and advance health equity. We recognize that strong primary health care is essential to achieving these aims. Primary health care improves health outcomes, advances health equity, and is critical for addressing the pressing health needs of our day, such as the COVID-19 pandemic, the mental health and substance use disorder crises, and the need to improve maternal and child health and wellness. Unfortunately, many people lack access to primary health, and primary health care is also under-resourced. And like most healthcare fields, the workforce is shrinking and struggles to maintain well-being. And the COVID-19 pandemic significantly threatened the financial stability of many primary care practices. As a result, and in response to the NASEM Primary Care Report, OASH is leading an HHS initiative to strengthen primary health care. The initiative to strengthen primary health care aims to clearly articulate the federal government's plan for high-quality primary health care for all, which will improve the health of individuals, families, and communities, and improve health equity. Our first task is to develop an initial HHS action plan that outlines initial actions that HHS can take to strengthen primary health care, expanding on our current agency activities. Now, strengthening primary health care is not like flipping a switch. It will require not only initial actions that we will implement over the next few years, but also further actions implemented over time to achieve our shared goal. In developing the HHS plan, we will think ahead about the sequence of actions taken over time that are needed to achieve a federal foundation of strengthened primary health care. We will also recommend actions to set up an infrastructure in HHS to continue its focus on strengthening primary health and monitoring progress and impact. OASH is working with HHS agencies and other federal offices and departments to coordinate the development of the HHS plan. We will use the NASEM Primary Care Report to guide the development of the HHS plan. OASH is also engaging diverse stakeholders and subject matter experts, including individuals, families, and communities, to learn about innovative approaches, needs, and challenges to inform the HHS plan. To ensure broad perspectives, OASH plans to release a request for information later this year. Please watch for this notice in the Federal Register. The federal government plays an important role in shaping primary health care, but it is not the only actor. Strengthening primary health care requires an all-of-society effort, with actions to be taken by many, healthcare payers, providers, and purchasers, communities and patient and family advocates, state, local, and tribal governments, and public health departments, as well as academia, professional societies, trade organizations, and philanthropic organizations, and more. Today's webinar is for all of us to learn about what individuals, families, and communities need from primary health care and how we can make that happen collectively. Collectively working toward a shared goal. Thank you, and please enjoy the webinar.
We're so grateful for the Admiral's comments opening us up. And our first plenary this morning is designed to review what the desired model of primary health care is. And for the audience, what Dr. Zhao and Dr. Levine both spoke about is the opportunity here for dialogue for external stakeholders to inform and talk with internal stakeholders in HHS about what a plan, what an infrastructure should look like in HHS to support the national capacity to deal with health priorities, but also to help states and state efforts to do the same thing. So please use the Q&A function to send us questions or advice. Include your name and affiliation when you do that. The webinar is being recorded and will be archived online after the webinar on the same website where you found this connection. The bio sketches for all of today's speakers are available on the project website, so we will be giving a truncated introduction to our speakers. And for this session, each speaker will speak for 10 minutes, and then we will use the remaining time for addressing your questions and comments that you put into the Q&A. So today we're going to hear from 4 speakers on this plenary group. Merit Felsian, who has been partnering, advocating, and collaborating in primary care research for nearly 20 years, comes to us today from Sterling, Colorado, in Northeast Colorado. In her efforts, she strives to bring her lived experiences, practicality, and desires for quality primary care and improved health access. Our second speaker is Jim Mold. Dr. Mold is a family physician and geriatrician who spent most of his clinical and research career in Oklahoma building one of the most important and vibrant practice-based research networks. He developed a person-centered conceptual framework for primary care called goal-oriented care, in which the clear and direct focus of care is on helping individuals clarify and achieve major health-relevant life goals like survival and quality of life, growth and development, and a good death. Lloyd Minchner is our third speaker. Dr. Minchner is also a family physician who has long worked to link communities, healthcare, and public health in order to achieve community health. His career has been based at Duke University, where he has served as a family practice team leader, medical director, residency director, founder of the Division of Community Health and the Duke Center for Community Research, and finally as chair of the Department of Community and Family Medicine for more than 20 years. And our fourth speaker is Cameron Lee Matthews. Dr. Matthews is currently the Chief Health Officer of City Block Health, a transformative value-based healthcare provider integrating medical behavioral and social services for Medicaid and dually eligible and low-income Medicare beneficiaries. So I will turn over the comments and discussion to Ms. Felsian.
Good morning, and thank you, Dr. Phillips. Thank you to everyone for inviting me today. It's quite an honor to join you. Yes, I am from northeastern Colorado. It's the prairie part. It's agrarian. It's sparsely populated and known to many as flyover country. I happen to think it's amazing. I'm an active partner in my family's dryland farm. We are the 4th generation to work this land, which exists on the ancestral territories of the Cheyenne, the Arapaho, and the Oglala Sioux. I spent decades working at our local community college, supporting a diverse array of students as they navigated a complex, often expensive, and highly personal endeavor, not unlike healthcare. And as Dr. Phillips said, I've spent nearly 20 years as a community partner to advocate for primary care health research and patient and community engagement. I've been able to do this because I was invited to participate and seen as someone with lived expertise in my community. I stayed because my voice was valued and the work makes a difference. And to admit, I'm curious. I highlight this work because I stand on the shoulders of two groups today. The first is a group called PACE, Patient and Clinician Engagement, who for nearly 10 years has invited and trained dyads, a partnership of patient and clinician, in order to as a team, work on patient-engaged research and advocacy for primary care, and all within the warm embrace of a group called NAPCRAG, North American Primary Care Research Group. And the second is High Plains Research Network Community Advisory Council, which has a long history of community collaboration and practice-based research across Eastern Colorado. This partnership works to ground and inform the research, build knowledge and capacity at our regional practices, but also to educate and activate those who reside here. Several years ago, this group set out to ask similar questions that you're asking. What is a medical home? What do patients want from primary care? And both groups have contributed substantially to my comments today. I'm going to frame my comments as wants this morning, perhaps even on the idealistic side, because I'm going to really speak from that perspective. What do patients want? And I'm happy to hear Dr. Rear Admiral Levine and Dr. Phillips sort of frame it in that way too. Patients want relationship in order to have a productive partnership. Patients want and deserve a process by which a respectful relationship can develop, where one is heard, seen as a whole person, can ask questions, get answers, have discussions as if in a true partnership. A little give and take happens, a place where trust develops. As one PACE member said, I want someone who knows me, a place where, not just my medical record. And then within this relationship, patients want quality time. And I'm going to pause here. When I say this, I think that you hear me say they want more time. And that is an assumption I think people make. But rather, I want to say they want better time, better spent. So this could be a portal chat, a 2-minute phone call, a 5-minute telehealth visit, or a real office visit, short or long. Sometimes I want them to be short and the practitioner makes them long. It's the quality and the timeliness and the purposefulness that is key here. We want quality and comprehensiveness. Obviously, we want clinicians who can provide the best care and information at the right time and to know when they need outside consultation. But you know what? I also want clinicians who are curious, who access new knowledge, and who use evidence-based science. Primary care should never be seen as lesser, but always top-notch and not just the gatekeeper to access some specialist. We want practices that innovate, participate in research, strive to improve and advance the science. And as part of this desire for learning, thriving practices, hopefully they care about quality improvement so much that they implement a patient advisory board to assist them with assessment at their practice's level, to discover where there can be meaningful, impactful, and specific improvement. In the right environment, these advisory boards can work in an equitable and efficient way for quality improvement. And this effort of this board should be valuable, productive, and insightful, and that the practices wouldn't want it any other way. As part of this comprehensiveness, patients want coordination of care. And I think there are 3 layers to this. The first being, help me coordinate my own self-care. Teach me the steps to care better for myself and my family. Partner with me. Help us so that we can keep ourselves healthier. But I also want my primary care clinician to be my team's quarterback, someone who knows the immediate plays and the long game, someone who will help me navigate a complex system and keep an eye on the ball. Of course, specialists and hospitals may need to get involved, but at some point my care comes back around to primary care. So how will my primary care clinician collaborate with the management of this overall big picture? And thirdly, patients are starting to really look for this team-based approach, obviously to the best of the clinic's ability. This was mentioned by many of the people who helped inform me today, saying that the medical assistant is as valuable as the doctor, and integrating other components like imaging or labs, physical therapy, behavioral health, dentistry, community health workers, or fill in the blank, provides a much more seamless and better sense of care. Patients want accessibility. My specialists in my community are a 90+ day wait or a 4-hour round trip drive. But my primary care is local. The clinic is nearby. It's easy to access. And as I said, we can use phone, telehealth, or nurse-only visits. But more importantly, my primary care is embedded in my community. They have a pulse on our trends, our stressors, and our needs. They also know the resources, the strengths, and our assets. Hopefully, they have a strong working relationship with area therapists, mental health providers, ER, law enforcement, faith-based organizations, and our schools. They also know the local news. Was there a recent devastating car crash, a suicide, an apartment fire? Is the local farm economy struggling, or did a factory just shut down? Is the immigrant population suffering due to some stressors from abroad? Knowing the community makes for better personal health and begins to address these social determinants of health. And finally, I want permanence. And I have to tell you, this worries me the most. I want clinicians and clinics that thrive, and because they're thriving, they will stay. I want them to get reimbursed enough to have sufficient staff to support a team-based approach and staff that are well-trained and integrated and reflective of the community. I want them to have a manageable patient load so they can purr along without being constantly overburdened and burning out and quitting. I believe that the patient load is oftentimes unmanageable. And I want an educational pipeline that's robust and has its fingers reaching deep into the community, and a career track that is fulfilling and successful and brings these practitioners back to these communities. So I'm going to wrap up. I didn't mention affordability, payers, reimbursement, or effective insurance on my list. And clearly these are incredibly important. They're part of the triple aim, and I believe the giant elephant in the room. But I don't know how to talk about this. I don't think I've said anything unique here, and I hope this doesn't seem like pie in the sky wishes. One can argue the fine line between wants and needs. When a community asks for sidewalks and clean tap water, are those wants or needs? I would argue they're both. I don't think it's too much to expect a system that supports all these aspects, a primary care structure and foundation that changes the ethos of how healthcare is delivered. Why can't patients in primary care be stable, accessible, comprehensive, allow clinicians and patients to thrive within the community, work on whole person, structures, and with authentic and trusting partnerships, one that prioritizes the patient and allows for a with relationship, not an at relationship, is embedded in and reflective of the community, and by virtue of these efforts is community-centered and community strengthening, that engages patients and consumers as partners for quality improvement because they recognize their value and wisdom, is affordable, understandable, and has an easy payment process, and improves health outcomes and contributes to health equity in our communities. To quote another PACE member, everyone, and I mean everyone, should have a great primary care provider that embodies these characteristics. Thank you.
Ms. Felsen, thanks so much for that partnered perspective. You clearly have a deep understanding. Thank you. Jim Mold, are you ready to go next?
I'm ready. We're drawn together on the webinar today by a common mission to strengthen primary care, and by a common set of goals to enhance its quality, growth, and durability. My objectives today are to begin to convince you that primary care is qualitatively different from secondary and tertiary care, that it needs a more robust conceptual framework, and that goal-oriented care should be a key component of that framework. And I want to leave you with some thoughts about how goal-oriented care could be implemented. Next slide. Primary care is qualitatively different from secondary and tertiary care. Some of the differences are listed on this slide, and they're reflected in the National Academy of Medicine's revised definition of primary care. Yet for historical reasons, it never developed a satisfactory conceptual framework. That void was gradually filled, despite some resistance, by the very appropriate framework used in secondary and tertiary care, which is a problem-oriented framework, a problem-solving approach. And that's certainly relevant to primary care, but it's insufficient for guiding the full range of primary care tasks and functions. Next slide, please. Collaboration is a key function of primary care, and effective collaboration requires that those involved have a clear understanding of and support for a common set of goals. Within the goal-oriented care framework that I'm describing, a goal is a desired outcome for which it makes little sense to ask, so that what? For example, a goal might be to be able to have the energy and endurance to play with my grandchildren for as long as possible. That's certainly a goal of mine. That requires no further justification. It doesn't make any sense to say, so that what? Quitting smoking, on the other hand, is a strategy, not a goal. And reducing the risk of a heart attack is an objective, but not a goal. Goals are uniquely human, inseparable from the person to whom they belong, and grounded in personal values, aspirational with no upper limit. Next slide, please. The World Health Organization definition of health, while inspirational, provides little guidance about how to organize services or how and when to apply healthcare interventions. I think a more helpful definition is that the ability to derive as much joy and fulfillment as possible from life's journey. Using that definition, it's possible to derive 4 different types of overlapping life goals. The first is to prevent premature death and disability. The second, to experience the best possible quality of life. The third, to optimize personal growth and development. And the fourth, to experience a good death. Focusing on those goals could provide a conceptual framework to guide the organization and delivery of person-centered, relationship-based clinical care. Consistent with DC and Ryan's self-determination theory, a goal-oriented approach supports connection, autonomy, and competence. Next slide, please. This idea that I'm presenting to you is so simple and obvious that the initial reaction of many healthcare professionals is, that's what we do. However, there's very little evidence of that in the design of record systems, clinical notes, quality metrics, research methods, or reimbursement structures. So for clinicians, I propose that goal-oriented care is going to require a significant mind shift, a shift from problem solving to goal attainment, and from standardization to individual prioritization. It's going to require some changes in the way we educate and train primary care clinicians, a shift in the medical school training from problem-based learning to goal-oriented teaching and learning, and from traditional residency training to interprofessional team-based training. Next slide. Next slide, okay. For practices, it's going to require integration of key competencies, that is, integration of additional team members, particularly rehab therapists, social workers, behavioral mental health professionals, and so forth. We're going to need new research methods that allow for individualization of interventions and outcomes, and longitudinal comparative impact research to inform prioritization and predictive models. And the required changes in mind shift and focus will reverberate through the entire healthcare system, accentuating the foundational role of primary care. Next slide. So again, primary care is different. It's foundational. It's qualitatively different from secondary and tertiary care. Partnership, coordination, and collaboration require a common set of agreed upon goals, and those goals belong to the patient. At all levels, this goal-oriented care model could provide a frame, just as the foundation of a house creates its shape and size. Primary care should determine the shape and character of the healthcare experience for each person. A house also needs a sturdy frame, and goal-oriented care could provide that frame. Next slide. Let's skip to the last slide for a moment. So I just want to pause on this slide because if I've achieved my objective and you're beginning to be convinced, please feel free to contact me through email with questions or interest in collaborating. And jot down my email address and take a screenshot of this slide. I've also provided a couple of websites and some key references. Now, if you go back to the previous slide, and then I think if you hold down the control key and click on the link, it'll take you to some suggested implementation steps. Perhaps. There we go. I think we're there. Okay, so let's skip to the second one. I'm not going to go through all 23 of them. I don't see it. Can you skip to the second one? Is it showing? Well, let me just, okay, there we go. So I think that residency training is going to need to be team-based. And I know that some residencies have experimented with that, but teamwork is so important to primary care that I think we need to start training the team together. Now skip to the third one. This is particularly important. It may not directly relate to goal-oriented care, but it's so important I wanted to highlight it. And that is that we need primary care health administrators who are experts in primary care, not those who are trained in hospital administration. There are very few programs that train primary care administrators, and I think that's a really important implementation step. I'm going to stop at that point. There are 23 of these steps, and they're accessible through that link that I provided. Thanks for listening, and please contact me if you want to talk further about this.
Dr. Mould, thank you so much. And there's some Q&A, I think, that's quite relevant to some of the points you just brought up. Our next speaker is Lloyd Michener. Dr. Michener.
Oh, first question is, can you hear me okay? Yay, okay, we're off to a great start. So I'm gonna be building, well, first, thanks for the invitation. And I'm gonna be building on some of the comments you already heard and sharing a few stories of communities in primary care working together and the lessons learned along the way. I'd actually like to start by thanking the practices and communities whose stories I'm sharing, apologize for the information left out and keeping these stories very brief, and also apologize to the many practices and communities whose stories are equally or more compelling that I've not been able to include here. Let's go to the next slide and we'll dive in. So key points, I'm gonna actually read this because it's important, is communities differ. If we didn't know that before COVID, we do now, in their histories, their cultures, their strengths, and their challenges. And primary care is most effective when it's engaged with and responding to its communities as part of larger partnerships for health. Let me show you what I mean by that. Next slide. Let's start with the Bronx. This is actually a couple of years ago when there was a state innovation model working across the state to reduce preventive admissions, and they'd noticed high rates of asthma and asthma admissions across the Bronx. They did really nice work working with the primary care practices around asthma care pathways and action plans, which were really important, had value, but had relatively little effect on asthma admissions and ER visits. So the team did something interesting. They actually convened a meeting between and across Montefiore, which is the dominant provider, New York City Health and Hospitals, including their health centers, and community leaders to share the issue and concern and to talk about what might be done. In advance of that meeting, Montefiore did something really innovative, and they geomapped their own asthma data and discovered something that they didn't realize, which was there was a 300-fold variation in asthma rates by address across the Bronx, a pattern that was not visible to Montefiore, to the public health groups, or the primary care groups. And they didn't actually know what was going on with that. I'll show you that map on the next slide. Those hotspots, next slide, in red were where there was high rates of asthma, and the green is much lower. Reason wasn't clear to the clinicians, public health groups in the audience, but at the meeting, the Latino moms immediately recognized the pattern because it was their kids who were sick. And they had been working for years to get the mold and the rat venom cleaned out of the heating vents of their apartments in some of those hotspots, but had been unable to get much traction. There were a lot of housing code violations. So a partnership was formed on the spot with the kids in the hotspots receiving care management from the practices and a coordinated effort between Montefiore, the practices, New York City Health and Hospitals, and the housing inspectors to clean up those housing projects, to clean up the vents, and to get low interest loans from the banks to the landlords on the condition that they would not raise the rents, trying to avoid gentrification. That coalition reported about an 80% reduction in asthma ER visits and admissions in the following year. And this was not unique. It's been duplicated, and I show on the slide an example from Boston. It's been done in Cincinnati. We did it across North Carolina. This idea of partnerships that bring in the community, go upstream and look for data, co-design solutions, and find and use local data is really effective. Next slide. The next example actually comes from near where I live, the Walltown and Lion Park neighborhoods of Durham. These are the communities around Duke University. They've historically been transitory, high numbers of African American and increasingly Latino community members, low income, high use of emergency rooms. They're walking distance from my own practice and a bus ride from a very good federally qualified health center, both of which have medical homes. But interestingly, folks often preferred to go to the emergency room rather than come to our offices. And we tried reaching out and teaching people the value of primary care and medical homes, and that was useful, but it had relatively little impact on ER visits. So then we decided to do something different for us, which is actually, rather than having folks come to us, we went to them. And we actually started going to community meeting and asking what the issues were. And it was eye-opening. You can see them on the slide. Everything from language and culture, sexual orientation, transportation issues, especially the FQHC, but payment, and just fundamentally trust. The community didn't feel like we were part of their community. So we asked them, what did they want? What would work better for them? Next slide. And they said they wanted a practice that they could call their own, that they considered part of their community. So we had multiple meetings. We had multiple meetings with the multiple community groups, the multiple churches, the more than a dozen, about what would work, how would we do it, how would we staff it, what would be sustainable, the political action committees, and with help from multiple partners, especially Duke, our federally qualified health center, those action committees. We co-designed a new clinic in an unused house, rebuilt it as a clinic, staffed it with a bilingual PA supported by a family doc from the department, and it was jammed from day one. And it led to a dramatic drop in ER visits, and then to additional sites and programs across the community, including an LGBT medical home, something which we really sharpened our thinking about by listening to our community. Next slide. My third example actually is about technology, something that we often ask, what would it take to bring into primary care and healthcare? North Carolina, like everywhere else, has a lot of unmet social needs and no system to really help connect people with those needs. And rather than assume we answer, North Carolina Department of Health and Human Services held multiple meetings with people seeking those services, with our community-based organizations that would often help provide it, and with practices, especially our federally qualified health centers, our primary care network across the state, about what sort of program or platform would work. And the answer was to do a statewide platform to really help link people with the services, a no wrong door approach. It's called North Carolina Care 360. Next slide. It's been up for over a year now. We started it before, actually 2 years now, started before COVID and then had to really accelerate as COVID struck. So we're now in all 100 counties. We are working with almost 3,000 North Carolina community-based organizations, 6 health systems, over 700 practices, including just about every FQHC. And so far, we served about 88,000 people, mostly around food, housing, and transportation, but all told, there are 12 groups of services provided. And what quickly happened, some of you may have foreseen it, is that the capacity of our community organization to handle that, even with the streamlined referral process that this platform provided, that we really needed to build community capacity buy-in with those community-based organizations, which is what we're doing now. We're really doing community capacity building. Takeaways are really that we need the IT solutions, but we got to partner with our groups and co-design solutions, use an equity lens, look upstream, and support cross-sector interventions. This is a good example. Next slide. So this next one is an example all of us know well. In Durham, like most communities, the initial wave of COVID response largely bypassed our Black and Brown communities, leading us to inadequately recognize or support those most at risk. But in Durham, partially because of these previous partnerships, that quickly changed as the Duke family doctor, Vivian Martina Bianchi, who's on this call, but I think happy to answer questions. The colleagues in pediatrics helped convene a community Latinx advocacy group, which gathered data, proposed solutions, quickly helped the county, then the state adapt a health equity lens to COVID response. Next slide. The outcome, by the way, is that in Durham and then statewide, our Latino residents are more vaccinated than their non-Hispanic population. This coalition building advocacy using data was really effective in dealing with all the difficulties in working with those communities and bringing them into the fold and using a health equity lens. Again, elevate community voices, listen to the community priorities, and strengthen those partnerships. Next slide. This is what the model looks like. You may recognize it's actually an old model of putting the community in the middle and then wrapping the different groups around them, healthcare, primary care, most especially public health, educators, nonprofits, government, community development into a coalition. But let's go to the next slide. There's a newer model that just has come out from the National Academies, a group on assessing meaningful community engagement that really says community engagement is the core of all this. And you wrap the core principles of like trust, co-creation, inclusion, equity around that. And then you use that to strengthen partnerships, expand knowledge, improve health, and really create healthier communities as a result of that process. And I've given you the link on that. This is the summary. Oh, go ahead. Yep, we're just about done. This is the summary. Is the primary care is always important, but really most effective when it's engaged, when it's responding to its communities who differ. And as part of larger partnerships for health, the key steps are partnering, use a health equity lens, use local data, which you may have to find, go upstream to look for causes, bring primary care to where people are, use teams, support partnerships, and build community capacity. And a federal policy office to do that would be enormously helpful. We need that. This is my last slide. Next. Because we still have a long way to go. This is pre-COVID. Just let me remind folks that pre-COVID, women were dying at higher rates than 10 years before, and the pattern and reasons for that are not entirely clear. And it's going to take these partnerships with other sectors to reverse this and make our communities healthy. Primary care is a key role of that, but it's part of larger partnerships for health. And with that, I'm done. Thank you.
Well, thank you so much for taking us outside of the clinic walls into community partnerships. Your leadership in this for the last decade since the IOM report on integrating public health and primary care is we've just seen the tip of the iceberg of your work. Thank you. Dr. Matthews.
Great. Thank you so much, Dr. Phillips. I am very excited to be here and to honestly join this conversation. I'm going to work without slides just to share a good bit of our experience, because I'm definitely coming from a different space in this startup world, in this value-based model that I'm coming from, that I recently joined here at CityBlock. So I'd love to just share some of our perspectives. I completely applaud and am in agreement with Drs. Felzine, Mold, and Mishner. Everything that they've highlighted is indeed, honestly, what we are trying to promote through our own model. And I'll go into that in many ways. But I think bottom line up front, I definitely think that we have a model, and I can make the case that we can address access to care, equity, provide whole health, provide goal-oriented health, aligned with the right incentives, aligned with the ability to implement high quality care, because we've been able to step away from more of those traditional payment structures that, of course, the report definitely emphasizes is one of our limiting factors. A little bit about myself. I came to CityBlock Health now about 3 months ago from the VA, where I really saw the true strength and value behind a system with a mission focused, of course, on veteran well-being through integrated means, primary care, behavioral health, the entire system. And of course, not just focused on services alone. We didn't necessarily have the restrictions of fee-for-service model and payment, because of course, we have been able to, in the VA, really address veteran needs end to end. Whole health, of course, was critical and necessary, because we definitely saw the veteran as more than a patient. And that even came down to the language that we use. We don't refer to veterans in the VA as patients. They are indeed whole persons. And we want them to maintain, to self-manage their own care, to be supported by what we're able to provide, as well as partners in the community for their daily experiences. So I turn to my experience now at CityBlock Health purely because I have a desire to join and continue to promote a model that provided the same sort of integration and mission-focused care as the VA, but to also be a part of the innovation and transformation that I think we are all seeking in our system. For those who don't know, CityBlock Health, as Dr. Phillips introduced earlier, we're a value-based healthcare provider for Medicaid, low-income Medicare, and dual eligible beneficiaries. And we particularly, of course, are targeting those most vulnerable and marginalized communities. As a startup, we're in this new space where some of our other competitors / colleagues in the value-based world are more in that MA space, but we're purposefully speaking out members that are of the highest risk, that have complex and overlapping conditions, that have those behavioral health diagnoses. And we really continue to scale our model. We're in 5 markets, opening in the 6th in a couple of months, and continuing to grow from there. Our emphasis is about equitable and high access to care for all members, not just the portions of the population that have immediate physical access to our clinics or have insurance coverage or even literacy enough to engage. We think really we're engaging with a group of patients that probably other primary care practices find it very difficult to engage with. Obviously, I come from the community health center world as well. FQHCs, we've been doing this from our creation, but sometimes there's still a bit of a financial decision there that doesn't necessarily allow us to approach our Medicaid patients truly from that holistic standpoint. And this actually perpetuates more of the trauma for our patients as we think about how people are being disrespected, how people are being maybe pushed out of an exam room because we need to continue to push volume over value. We really want to assure for our members that they're receiving care that's respectful, that's based on trust, that is based on a relationship. And that's really what we hope to provide. So similar to other FQHCs and the like, we definitely take a multifaceted approach. We integrate medical care with behavioral health in-house, as well as social care services. So we're actually going to address their food insecurity needs, their housing issues, as well as transportation. We're going to look at their connectivity. We're going to look at family engagement and caregiving, all under the auspices of a value-based business model. It allows us the flexibility to actually intervene and invest in really dynamic ways because our members are, again, the most complex and have complex needs, and it's about the sustainment of our interventions, of our care that we're providing them, not just that fee-for-service intervention that unfortunately is continuing to increase costs throughout our systems. So our model, we actually contract with health insurers in order to assume full risk for our members. And we are paid based on the outcomes that we actually able to achieve. And since 2017, we've seen those cost savings. We've had meaningful reductions in emergency department visits, inpatient admissions, and overall improvements in engagement, which Dr. Heisner, you just highlighted, I think is dead on, that we need to actually be meeting our community members where they are. We need to have that meaningful community engagement, both in building our model, which we have, but and also sustaining those services for individual members. We definitely seek to also understand and address their social determinants of health, which traditional, unfortunately, medical model does not necessarily allow us to address in a broader systematic way, because again, the fee-for-service model doesn't necessarily allow it, where I'm actually able to contract with and pay for additional services to work with, obviously, food banks and the like, but then also broader partnerships, even in the digital space, in order to truly address a member's ability to live a full and healthy life, not just receive reactive medical services. So each member is assigned a community health partner. We are all very familiar with the community health worker model. We really do support these CHPs as the lead member of the team, actually. They are the main point of contact for our members. They are the ones that help us develop those personalized, goal-oriented care plans, and really also help then connect the members to care as well as social services. The rest of the care team is integrated, multidisciplinary, both behavioral health and primary care, whether we're providing primary care services directly to members or providing that care management because they actually are enrolled with an FQHC or another private practice in the community. We actually try to meet the member where they are. And our new phrase is actually, what is the right dose of city block? Not every member will need the exact type of care, full-fledged end-to-end care team work that we may be able to provide. So we like to tailor that through quite comprehensive onboarding assessments. And we're really trying to shift the paradigm in order to make sure we're focused on outcomes and experience and well-being, as opposed to, again, volume. We tried to shift the paradigm of how care is delivered as well, too. That, of course, we've all seen during the pandemic. We've all done that pivot to connected care, to virtual care. For us, that actually was part of our foundational model, that we were not going to set up offices and have extreme overhead costs, but that we're actually going to do care virtually and in the members' homes. So we have at-home teams where we're sending members staff into members' homes, where we're connecting by iPad to either their primary care physician or even emergency physicians that we actually have on staff, so that we can provide more acute care services. Of course, directing them to a local facility if something more critical is needed. But we promote kind of a call us first option, because so much of that care can be diverted. So much of that can be kept in the home, where they actually might sustain better outcomes because of, unfortunately, that disconnection that they have when they walk into a hospital, that lack of cultural humility that a lot of times they see when they interact with the system. So much of this, again, is about making sure that our members are receiving the care that they need and of the quality that they need it. So our recognition that good healthcare goes beyond just what happens in the doctor's office or even with a virtual visit is really tied, of course, to the strength of our workforce and the diversity of our workforce. So much of that community engagement, again, like Dr. Michener discussed in the Walltown neighborhood, I thought that was perfect. We exactly are really pulling our staff, our community health partners, even clinicians from the communities where our members live and work. so that we're actually understanding their issues and we're focusing on their immediate needs through their member action plans, as we call them. And our providers also understand that, preventive care, reactive services, even in the typical medical model, may not be at the top of mind for our members. So we have the ability through our value-based model to really address where they're sleeping at night and how we're actually able to maintain the members' focus in our decisions from day to day. It's not about the length of time that we're meeting with them. It's not about where we're meeting with them. It's really about making sure that those members' needs are, again, being addressed. So we really believe that we can continue to improve healthcare and continue to see these outcomes because our model is most importantly anchored on trust and longitudinal relationships. And I think that was just so much of the strength that we saw in this report implementing high quality healthcare. And that is really the strength of our model at City Block, where we are really seeking to understand and even saw this so much more through COVID-19. I can think of multiple stories that I've even seen just in the last couple of months where the challenges that our members face really are, again, not about just purely connecting with us as a care team, but it's about their life outside of healthcare, that their broader concept of health and well-being needs to be addressed, and they will only trust us in order to do so. They will only take our recommendations to have a vaccine. They will only perhaps call us instead of walking into an emergency department where they feel that disconnect if we've established that relationship with them. So it's about that engagement even before the care relationship traditionally starts, although we consider it starting way early on. So much of support of this model is about our data and analytics capabilities as well, too. I think that's also one of the strengths of our ability as a startup. I hate to say it like that, but the ability to have systems that are connecting our EHRs, that are receiving data feeds from all of our different markets to really look at a data-driven approach and a tech-enabled approach with how we're providing care management, so that our CHPs are in the system, that they're actually building out those action plans so the rest of the care team can actually see it. That's also truly one of the strengths of our model as well, too. And we actually, our tech team, even within City Block, it kind of blew my mind coming on board how large we actually focus on this, and we'll continue to be innovative in that space as well, because again, that's what's necessary to improve the outcomes for our members. So I thank you guys for allowing me to just share our model as potentially one to look towards, and I appreciate the conversation. Thank you all.
Matthews, thank you so much, and thank you to our whole panel. Guys, we have like 25 questions in the Q&A. Something that was mentioned throughout all of the discussion, from Merritt talking about the value of MAs being almost being equivalent to that of the physician in terms of their partnership with patients, all the way down through you talking about community health partners. Did I say that right? CHPs. Some of the questions that are in the chat are about the value of health coaches, about community health workers, about pulling even more of these disciplines and even some specialists into that primary care model to really deliver that more robust care at the point of care and into the community. And so I wonder if folks have thoughts about the training of those teams and the financing of those teams.
I'll take a first crack at that. It actually was in the chat as well. And that is that these are wonderful training sites once the community says it's okay. And the reason I add that is that if you lead with your learners, it can be perceived as they're not important enough for the faculty. So once trust is there, then it reminds people of why they went to their medical, nursing, dental school. The other part is that you can do innovative things, as Dr. Matthews was describing, and you use community health workers and doulas and really have people at PAs and NPs. I mean, I call microclinics are primarily staffed by PAs and NPs with family docs, pediatricians, internists involved as well. So folks get to see a style of practice to which they hope to be able to continue once they get into real life.
Completely agree. And I think right now, what we're most focused on, particularly because of the communities we're serving and just the needs that we're seeing, we're expanding our behavioral health staff on all of the care teams quite significantly, even having some of our community health partners with additional behavioral health training, mental health crisis training, but then also looking at our LCSWs as actually some of their care managers. So instead of having the RNs doing that solely, having a mix of different experiences, again, based on kind of the risk level of the member, their needs, having them even assigned. We have pharmacy techs that are part of our care teams that are helping with medication management and our transitions of care from inpatient and in ED discharges, just so there's no, losses there. So we are trying to actually complicate the care team even more instead of simplify. We want to complicate it more so that we can actually expand the services.
And how do you finance that? I mean, in a fee-for-service world, it's really difficult to build that kind of a robustness. So what does it actually take to fund that, much less make it a training environment?
Yeah. So, I think the fear around capitation is still there, right? We're all still cringing. But I think that's where the data capabilities and really the risk stratification, I saw that question in the QA as well too, comes in necessary. So our actual per member per month increases based on risk stratification with all of our partners so that we can actually sustain staff in the proportions that we need, because we're actually being paid more for those more complex members.
Lloyd, brief comment, and then I want to get to Merritt and Jim.
Very brief comment. Yeah, which is, we tend to think of cost as being everything, paying for everything we do, but especially when we get outside the office, like cleaning up housing projects or building these IT systems, that should not be a practice expense. In fact, I think part of what we're trying to do with these models is expand the scope of who does the work and who pays for it, because the beneficiaries are not just health systems, they're the communities themselves and their resources that can be brought to bear. Thank
you. Merritt and Jim, one of the comments that came in from Charlie Homer is, I think is related to your goal-oriented care and trust. His comment was, it's moving from what's the matter with you to what matters to you. And I just love if you both could talk about that in the context of the trust building and the partnership and goal-oriented care.
Dr. Moll, do you want to start with that?
No, I want you to start. But I do. No, I'm sorry. I do have a comment about the last question. So before, I know everybody's concerned about payment models and teams and so forth. But before we decide on payment models and teams, we really need to decide what we're doing, what we're about, what we want to accomplish. And I think that's what goal-oriented care frames. At least it's one way to frame it. And there may be other ways, but I think you have to start there. You have to have a conceptual framework, and then you can begin to think about payment models and who belongs on the team and so forth. Okay, Merritt, go.
I saw something the other day that I thought was brilliant, and it said that you have to build relationships based on trust, that in fact, developing trust is the new litmus test in quality primary care. It was a Twitter thing, right? But it was legit. But I also want to say, and going back to Dr. Cameron and what everybody else has said, trust is on so many different levels. Everybody has clearly discussed the fact that trust is not only my trust with the person that I'm sitting in front of or with or side by side, but it's also, do I trust them with my family? Do I trust them in the community? Do they trust the community? And are they being receptive? And so we can't move close enough to that word, because it embodies so many other things. It's about the relationship. It's about the partnership. It's about the willingness to listen and think about goals together. And it's about achieving outcomes that are that are shared, not just did I get my diabetes patient numbers down and therefore my clinic's numbers are good, regardless of what my patients want or didn't want.
That's a really important point, and comes back to kind of Lloyd's efforts. How do you building that trust with the community and getting them to see their role in affecting health, build their confidence, see you as a partner, and particularly, Cameron, for the people you're looking to serve, that earning that trust can even be a higher hurdle. How does primary care need to be thinking, need to be trained in order to work at that next step outside of the clinic walls?
I'm not even the one to speak to this. Dr. Michener's work there in Durham speaks. I mean, we need to listen. We need active engagement. We need to take direction from the communities that we're serving, and we need to recognize that there's no single solution. It's going to be multifaceted. It needs to be multidisciplinary, and we have to innovate in order to address their needs.
Beautifully said. And get outside the walls of the clinic, go to the community and listen.
Well, and giving yourselves the opportunity to go out and ask, and then allowing people to really sense that their opinions and their thoughts and ideas are valued. And it's not something that happens quickly. Again, that requires relationship and trust too. So it's not easy.
I'm sorry, Merit, I interrupted. The thing I'd add is listen and then do something. Yeah, it's not enough to be heard is really important, but the trust comes from actually figuring out what you can do together based on the listening.
So we're out of time for commentary and questions. I hope our internal stakeholders at HHS hear the importance of that. It is not an easy thing for practices to develop that skill and develop those relationships. It's going to need support, and bringing all of those disciplines into the primary care space, affording them and understanding how they work together to meet goals of patients is not a trivial undertaking either. Well, thank you all. Thank you so much, Merritt and Jim, Cam, Lloyd. Thank you for this plenary opening session of our workshops. I am going to turn it over to Dr. Kevin Grumbach for our first panel.
Great. Thanks, Bob. As we're making the transition over, welcome to the second panel. I'm Kevin Grumbach, professor and chair of the Department of Family and Community Medicine at the University of California, San Francisco, and one of the founding directors of the UCSF Center for Excellence in Primary Care. So the next panel is going to discuss how we measure primary health care for value, impact, and investment. And we have three wonderful people to join us for this discussion. First is Rebecca Etz. Dr. Etz is a professor of family medicine and population health at Virginia Commonwealth University and co-director of the Larry Green Center and chief executive office of Smart Measures, LLC, an internationally recognized expert in primary care. Jack Westfall is our second panelist. Dr. Westfall serves as director of the Robert Graham Center, which aims to create and curate evidence to inform policies that support primary care. Our third person on the panel is Chris Kohler. Mr. Kohler is president of the Milbank Memorial Fund, a 116-year operating foundation that improves population health by connecting leaders with the best information and experience. So again, we'll have each of them share some of their thoughts for brief presentations, and hopefully we'll have some time at the end for question and answer. So those of you in the audience, please go ahead and submit some questions that we can then use to stimulate some of the discussion at the conclusion of this panel on measurement. Let me turn it over to Dr. Etz.
Thanks, Kevin. I appreciate it. I know, Zoom all day, right? I'm going to ask you guys to stick with me, wake up a little bit. Don't check out. The facts here are somewhat sobering, and they're baked into the system. They have been for years. A well-functioning healthcare system has a minimum 40% of its workforce in primary care. In the US, Over 50% of all outpatient visits happen in primary care, yet it's 33% of the workforce and 7% of the national health expenditure at best. Primary care is a set of scientific disciplines that must advance and grow as the needs of the population advance and grow, yet it receives 0.4% of NIH funding, again, at best. We've no federal coordination and no national database. I personally know of 31 different policy groups working on primary care finance reform right now. All rely on claims data and credentialing to identify primary care, and none have the same definitions. In 2019, primary care saw 99% of respiratory concerns. That's over 185 million visits. Then COVID, a novel, deadly, and respiratory virus. Emergency financial support was swift, but primary care received less than 3%. That's an estimate since we have no way to track it. PPE was hard to find and hard to purchase for the first 6 months. Half of primary care was unable to get what they needed. These physicians died from COVID at a rate 5 times that of any other discipline. For the safety of the population, they switched from in-person visits to telehealth in 3 weeks, having received no capital investment and with no funding mechanism. This is how we cared for our largest healthcare platform. Next slide, please. I run a regular survey of primary care clinicians and have since the start of the pandemic. I often get asked, if it's so bad for primary care, how many practices closed? How many practices went bankrupt? With no national database, how do I answer that question? I'm going to ask that you pull away from your email and your phone for just a sec. This is the heartbeat of primary care, and the effects are additive. Next slide. From our survey that closed 20 days ago, only 22% of practices are fully staffed. 44% have open clinician positions they can't fill. 62% know clinicians who retired early or quit during the pandemic. 29% know practices that have closed, and 40% are getting more patients arriving every day from closed practices. Burnout is at historic highs, resilience at historic lows, and 25% expect to leave primary care within the next 3 years. We have a new surge coming. And in our survey from December, 67% of clinicians endorsed the statement, "We are clinically fragile. When is someone going to notice?" You see, measuring is more than holding primary care accountable for population health. It also means holding the health system accountable for appropriately defining and supporting the work of primary care. No one thought Bear Stearns or Lehman Brothers could collapse, but they did. And I assure you, primary care can do the same. Next slide, please. A measure is just a number, and it's meaningless without context. 42. If you're my generation, could be the meaning of life. If it's a temperature, if it's a latitude, if it's a BMI, it means something different each time. Context matters. Quality is a standard that we create by comparing similar things with each other and our expectations. A good quality measure is not a target, not something to hit by any means necessary. That supports survival-like behaviors, not professional ones. Quality is meant to align with expectation and shared agreement on performance. Now, performance is about accountability, not quality itself. It's how well a task is done. Accountability for healthcare is not an ROI. It's not counting numbers of things or referrals made. Accountability is a measure of how well actions are aligned with a shared understanding of quality and professionalism. How do we measure primary care? Well, right now we take the shotgun approach. We aim every disease measure we can think of at it, and we see what sticks. There are hundreds of measures used, and they're largely disease and diagnosis driven. The problem here is that 80% of primary care doesn't involve diagnosis. It's symptoms and context and actions that must happen ahead of lab results. Clinicians apply their best scientific relational expertise to determine the best course. Social drivers account for 80% of outcomes, and yet we hold primary care 100% accountable. I'm going to ask you, have you ever tried to lose weight or increase exercise? Do you think it's fair we gauge your personal doctor's income on whether or not you succeed? What I want you to hear is that commonly used performance measures are not effective. They are great for clinical guidance, but they are inadequate for measuring accountability. Primary care measures need to align with its purposes and function, and that definition of primary care is well known. You can find it in the National Academies' recent report out last April. The facts aren't secret, but let me make them human. Primary care is a relationship and a first point of contact with the system. It's about being worthy of the public's trust and recognizing the wholeness of a person's dignity. It's a place in which you are known for the fullness of your biography, a place that's safe to be vulnerable, where your needs come first, and where an integrated narrative is created to make sense of the fractured experience of receiving healthcare. Disease metrics don't get us here, but measures to assess primary care can be made. My team created one, so I know it can be done. Now, there's an interesting pilot going on in Virginia that offers a great example of how to get from here to there. Virginia's task force on primary care set its focus on payment reform. As they started, it was clear that payment reform has to go hand in hand with attention to infrastructure, measures, and accountability. The approach they used is to first address pain points, reduce the burden of clinical measure reporting by a minimum half of current measures, while simultaneously identifying measures that hold clinicians accountable in delivery and the system and payers accountable to adequately resource primary care. Measures don't exist in a vacuum. It's context and shared expectations that invest them with authority. Let's make it the right choice. Thank you for your work and thanks for your time.
I will get started. How do we measure primary care for value, impact, and investment? Is that correct, Kevin?
That is, Jack, and you're on, we're seeing yours both, not your presentation view. Do you want to switch your display setting? Maybe. I think we had the slides, but they were, not in the display format. Let's see.
How is that?
Go to display settings, I think, and switch up at the display settings and put it. We're seeing where we have the preview of the next slide.
How is that?
One, I said, go up to displays, at the top there, Jack, there's show task. Yeah, switch, go, there you go. You're in business, all yours. Take
awesome. Okay, so Jack Westfall here. Thank you very much. I've been asked to discuss the value of non-billable services and the cost of providing comprehensive primary health care. I want to briefly review what we mean by billable and non-billable services. I will very briefly mention how most primary care is paid for through claims-based fee-for-service payments, and the growing appreciation and need to pay for primary care through non-claims-based payments. Because primary care sits in the context of the community, I've also been asked to briefly cover the concept of primary care and public health integration and how we might measure the primary care public health integration. Here's a brief outline of a common day in a primary care practice. It might not have all of these elements every day, but this reflects a typical set of activities that keep a primary care practice busy. There's a team huddle, reviewing emails and patient portal communication, reviewing labs and imaging, 8 to 12 patients per half day, maybe a group visit on low back pain or migraine, prenatal care. Proactively write a letter to my patients with diabetes, reminding them to come in and get their blood tests and their flu shot, and insert a brief educational one-pager. Work with the nurse to go over refill requests. Pop out over lunch to do a home visit. Come back and complete my morning charts, grab a quick bite to eat, and get ready for the afternoon. Only a very small component of this is billable. Fee for service billable. Patient encounters. Maybe something for group visits if I comply with all the billing regulations, and maybe a bit for a house call if I can justify the need. But most of this is non-billable. Primary care practices do these things because they are important to our patients. We must also give a brief nod to additional payment patient out-of-pocket expending on healthcare. Patients need to buy over-the-counter medications, supplements. They may join Weight Watchers or gyms or early childhood programs. Calculating the amount of billable services is relatively easy. Claims-based charges coupled with fee-for-service payments, add them up, and you get the value of billable services. But we also want to calculate the value of non-claims-based payments that payers are now making, the non-fee-for-service payments, capitation payments, value-based payments, per member per month payments, structured payments. If payers contract directly with an independent primary care practice, one can ascertain the total non-claims-based payments. But often these structured payments are directed towards the health system, the hospital parent of the primary care clinic, or the fiscal intermediary. So calculating how much of these non-claims-based payments actually go to support primary care can be difficult, if not impossible. Well, why does that matter? Because non-claims-based payments support all those other non-billable services that primary care wants to do for our patients. When revenue only comes from patient visits, that drives the practice activities, squeezes out the non-billable but important care, and leads to frustration, burnout, and perhaps even worse health outcomes. We need to have a better understanding of what are all the activities primary care can and will provide, regardless of payment type, those non-billable services. And we also need to have a better understanding of the non-fee-for-service payments already being made that truly go and support primary care. I'm going to switch gears a little bit, and I'm thankful that and happy that Dr. Michener described such great communities of solution examples of linking primary care, public health, and community assets. Because primary care sits in the context of the community, I've been asked to briefly cover the concept of primary care and public health integration and how we might measure primary care and public health. There is a host of healthcare and social conditions that need medical and public health attention. Diabetes, obesity, tobacco, substance use, mental, emotional, and behavioral health problems. Sometimes primary care is necessary, but not sufficient. Sometimes public health is necessary, but not sufficient. And primary care and public health reside in the context of community social assets. How might we measure the impact when primary care and public health work together to support primary care integration? The Community Health Index is a unique and robust measure of 3 evidence-based factors that contribute to population health. Barbara Starfield found that primary care physician density is associated with improved health outcomes. Public health has a strong history of responding to and improving local, regional, community health. And the social drivers of health are ubiquitous, crucial, and finally getting the attention they need. The Community Health Index provides a small area measure of public health, primary care, and social assets, which combined reflect a higher association with many health outcomes than any of the 3 individual components. Here we see the association of the Community Health Index with COVID vaccination rates. Higher Community Health Index associated with higher COVID vaccines. Community health index is also associated with COVID cases and mortality. And community health index is associated with obesity. The CHI is a measure of the coexistence of primary care and public health in the context of social assets or social deprivation. The CHI reveals local, state, and national policy levers to improve population health. The CHI could be used for community risk adjustment of payment, providing support for addressing the social determinants of health, while also taking into consideration the local healthcare infrastructure of primary care and public health. Primary care includes lots of activities beyond the billable encounter, and primary care sits in the context of community with an opportunity to work closely with public health. Measuring these components of primary healthcare may support and guide the effort to truly implement high-value primary care in all our communities. Thank you very much. We'll turn it over.
Thanks, Jack. We'll turn it to Chris Kohler next.
My goodness, I had mute on. I'm sorry, Kevin. So this is Chris Kohler. I apologize for the delay, folks. You'd think after 2 years I could learn how to do Zoom. I've been asked to speak specifically on the notion of measuring primary care spending. That is the portion of dollars that is spent in healthcare that go to primary care in the context of the measures conversation that Jack and Rebecca were speaking to. Next slide, please. And then I will outline current state efforts on that. Next slide, please. So this is a little bit more detail about the Milbank Memorial Fund and the work that we do. I want to keep the conversation going, so feel free to visit our website to learn more. Thank you. Next slide. So I want to place this in the context of the National Academies report that was issued last year, and the 5 overall action areas. We're going to be focusing the primary care measurement and primary care spending requirement occurs in the context of the payment objective to pay for primary care teams to care for people, not doctors to deliver services. Next slide, please. Next slide. We came up with 4 actions, and the primary care spending piece appeared in 2 of them. The 3rd action under payment, I'm directing CMS to increase the overall portion of healthcare spending for primary care by improving the Medicare fee schedule. And the 4th action, noting the role that states play in increasing the portion of healthcare spending for primary care. Next slide, please. It's important to define what primary care spending is. This builds on what Jack was just speaking to. It is fairly simple. It is the amount of payments going to primary care, both in claims and non-claims, over total payments going to healthcare, usually measured through the insurers and the insurer payments. And that includes both claims-based payment and non-claims-based payment. That comes up with a relatively easy to understand measure that we can call primary care spending. It's often called primary care investment. It is a measure of the entity that's being measured, whether it's a healthcare system, a payer, or a geography's primary care orientation. And I want to give a particular shout out to the work of the California Healthcare Foundation, who released a report this week documenting what states are doing around this work. And that's where I got this figure here. Next slide, please. This is key if we think about why primary care spending matters. And this is language lifted directly from the NASM report. We know the primary care oriented healthcare systems, however you define a system, a geography, a delivery system, a country, a payer, are associated with better population health and lower spending. Much of that work comes from Dr. Starfield. And we know that the portion of healthcare expenses going to primary care is a way to measure primary care orientation. There are other ways to measure primary care orientation. You can measure that in terms of primary care to physician, to specialty physician ratio, overall primary care physician staffing. The NASM committee chose to focus on primary care spending because, as a measure of primary care orientation, because dollars matter. Dollars are in effect a principle statement. Money talks, and the more money that's going to primary care, the more primary care oriented that delivery system is. And by this measure, the United States is at or below the proportion in other developed countries. Next slide, please. I would also note, as we go to the next slide, that primary care spending, for those of us who are understand the evidence around primary care, is a really effective way to engage non-healthcare stakeholders in the question. If, in my experience, if you ask non-healthcare people the portion of money that goes to primary care, they routinely give me estimates of 15, 20, 25%, and are shocked to hear that it is in fact 5 to 7%, depending on the payer group. So it becomes, in effect, a way to not only educate, but also to organize people around the importance of primary care and its relative undervaluing in the US. So now I want to focus on state level activity, if you will, the fourth action that was recommended in the NASM report. There are states that have set primary care investment targets. 2 of them actually have them as statutory requirements or regulatory requirements in Oregon and Rhode Island. We also have targets for increasing. So that means they've measured the baseline and they want to increase them. And they set explicit targets in Connecticut, Delaware, and Colorado. In addition, you have all these other states that have legislative action that's been proposed. Boston or Massachusetts came out just last week, where they are focusing on measuring a baseline of primary care spending, and in some cases, convening work groups to set targets going forward. And these are all the states that are listed here. You can go to the Primary Care Collaborative, which regularly updates this information on their website. Next slide, please. In addition, there are regional and national efforts to measure primary care spending. The New England states, through their Cooperative Services Organization, NESCO, had a standardized definition and then compared spending in the 6 New England states. The Primary Care Collaborative has released national measures. The Commonwealth Fund State Scorecard has a national measure. And then acting on a recommendation from the National Academies report, the Milbank Memorial Fund and the Physicians Foundation have convened a group to measure primary care spending as part of its Health of Primary Care Scorecard through work that the Robert Graham Center is doing. Next slide, please. So what we've learned is that states are growing their own definitions. The differences in results are minimal, but it makes comparisons hard. They're doing this mostly based on payer submissions rather than analyzing claims databases. Non-claim spending is important and it's hard to capture. It makes a big difference, as Jack was saying. The feds are conspicuously absent. And most importantly, as the NASM report documented, primary care spending rate appears to be decreasing, and meaning our system's getting more fragile. Next slide, please. We've identified 3 opportunities for state leadership. The first is to measure and improve primary care spending performance in their own programs. There are opportunities to measure primary care spending in all the different ways that the feds pay, including Medicare fee-for-service, Medicare Advantage, Medicaid, and in CMMI models. And it's important to note, as Dr. Starfield's demonstrated, we will not achieve health equity or longer lifespans without increasing our primary care orientation. The feds can help with standardizing the definition. The differences at the state level make comparisons hard. And then they can measure and research nationally through efforts through the Agency for Healthcare Research and Quality and understand the relationship between primary care spending and health outcomes more fully. Next slide and final slide. Absent this sort of federal leadership on primary care spending measurement, we will have no compass for Medicaid and Medicare. We'll have no way to measure its primary care orientation. and we will have a continued erosion of the primary care infrastructure in the country with attendant effects on population health, equity, and lifespan. Thank you. Look forward to the conversation.
Great. Thank you to all our speakers. And I think we'll all then reconvene now as a panel for a little bit of discussion. So let me, we have some questions coming in, and let me start with one, maybe with you, Chris, if it's okay. I think we know each other and be on first name basis for this panel. You know, you mentioned that how to actually capture primary care spend, and that there's, you know, different jurisdictions doing this. It's been a little bit challenging to come up with one standard definition. What's the data source? One of the people attending has raised, gee, there's a lot of primary care that may not be delivered in a traditional primary care office by other people who contribute to what we'd be describing as primary care services. Chris, is there a need from this, or something that this new initiative in strengthening of primary health care could assist with to try to move forward some standard definition that then could be applied consistently?
Sure. I think we always benefit from standardized definitions. I think the important message from the states is that they have not been willing to wait for that, that the kind of they feel the sense of urgency that Becca was talking about, and that they have to proceed. I think we suffer from a lack of comparison. So the fact that Oregon and Rhode Island were the first to move and really have no basis, they don't use a standardized yardstick. So we don't really know how the two are comparing. We need the Fed's help with that. We can't have Rhode Island and Oregon figure that out. But what they've said is we're not going to wait for that. And so I think it's, you've got the classic state-federal dynamic here, where the states are moving ahead, but we need to have the Feds define a standardized set of rules. And we'll be better off as a result of it because we can get better comparisons across the states. I think they're important detail questions. What I saw one in the chat, how do we deal with urgent care clinics? How do we deal, what constitutes primary care? I think those are really important. They shouldn't hinder the progress of states, of local entities moving on this while we work through these standardization questions.
Maybe then, yeah, so continue to improve, but don't let the perfect be the enemy of the good, and get moving on this. Is what
Thank you.
Chris. Yep. Jack, you raised a question again. When we measure primary care spending, there's always the other correlated or an associated question: how much of it actually then gets down to the frontline people working in primary healthcare? And I'm wondering, among the panelist group, is this a concern that if we measure primary care spend, and Chris, you may reflect on this in your experience in Rhode Island as health insurance commissioner, how do we make sure that those that spend isn't captured by where the value is not actually delivered at the front line? Is this something we need to be thinking more about, as you raised, Jack?
So I'll jump in, and then I'm very curious what Chris and Becca say about this. But I think it is crucial for us to understand when if we're going to expand primary care payment, and we're going to do that directly with the primary care practice, that's pretty easy to measure. It goes directly to the primary care practice. If it goes to a parent organization, a tertiary, a third-party administrator, a fiscal intermediary, or a hospital or healthcare system, requiring attribution of that money to the primary care, I think, is crucial. And I think this is one of those places where both states and the Feds can get involved. States can require reporting of the contribution of structured payments and capitation down to primary care. If they legislated an increase to primary care, they can couple that with legislation to mandate where that money is actually going. And I think that's not a difficult step. That's a short step to go from point A to point B.
So follow the money all the way to where it really hits home.
Yes.
At the home. Yeah.
I'll be a little bit controversial here, just to stir the pot. If I had to look, I never met a regulator who doesn't want to regulate, but if you gave me my choice of regulation, I would rather see health systems have truly population-based payments or downside risk than wade into their financials to try to separate out their cost allocations to figure out how much is going to primary care. If we can get health systems to accept population-based payments, the value of primary care will raise to the top. So if I'm gonna apply regulatory muscle, I'm gonna do it to getting the payment right before I get the accounting right.
Well, I appreciate Chris, and I'm going to just jump in and say I think putting any penalty that could potentially put primary care at risk is risky, and I think bending the cost curve on the backs of primary care is what we've been trying to do. And we've been trying to say, hey, primary care can save you money. What we should be able to be saying is primary care is going to provide more help, which may save money. And so we have to be careful about how we say downside risk, because as a primary care doc, I'm like, please don't give me downside risk.
Nope. Jack, I said health system. I didn't say primary care docs. I said
I
health
get it,
system.
but we have to
half of all primary care docs are employed. That's what I'm going after.
Yes.
All right, this is good. This is heating up. So, Rebecca, I think we need an anthropologist to weigh in here. So let's turn to you now. I mean, you can speak to this issue, Becca, but I had a different one for you, unless you want to tackle this one. But, you know, Rebecca, you really pointed out that we're in this world of the shotgun approach. I think you characterized it, of just all these disease-specific metrics. You've and your team have developed a more holistic measure that's a patient self-reported measure of their experience. You mentioned the Virginia task force on this. This seems really a huge shift from the dominant way of being measured almost to death by 1,000 different measures in primary care. What do you think it would take politically to get all the entities that require these various, HEDIS measures, everything else, to accept for primary care a much more parsimonious set? And do you have some bright spots you can point to say it is possible to get this done?
Yeah, I think it doesn't. In some ways, it takes everything, and in some ways, it really doesn't take a lot. I think the idea of using appropriate measures scares primary care, because they're like, oh my God, please don't add another measure to our plate. I think it scares policymakers because they're new, and they're going to have to be new because we haven't had them, because primary care has been anemically supported at best for 30 years. But perhaps one of the biggest shifts is for us to really understand the difference between a clinical measure and a performance measure. We need clinical measures. God, we need a lot of them. We need as many as we can create. They give us guidance on how to take care of people. They help us to know what's good. It's up to clinicians when they encounter people who live ambiguous lives to understand that they have multiple conditions, and to take all the guidance and use their well-earned expertise in science as well as in the person in front of them to navigate what are the best choices for this person. And that's not based on any one clinical measure. That's based on a holistic approach to a person. So it means that we have to understand that clinical measures are not the enemy. They are good, but they are about professional behavior and guidance for professional behavior. Performance measures are about whether or not practices are delivering on their promise to provide equitable care for all. It's really just kind of that simple. And once we realize that division, then we no longer hold your doctor accountable for whether you're exercising enough. We say, you do that, your doctor can have conversations about you with it. What we want to know is, does the doctor respect you? Are they able to see you when you need to be seen? Are they competent in the delivery of their care? And are they worthy of your trust? It's pretty simple. We do have lots of examples of folks doing this. My friends in Colorado are a great example. Jack used to be in Colorado. He's now in DC. I'll forgive him. But the folks in Colorado do wonderful stuff. What Chris set up in Rhode Island is magnificent. Later, we're going to be hearing from Howard Half. What he's accomplished in Maryland is tremendous. There are some wonderful examples in Massachusetts. You could talk to Barbara Rabson about that. There's just about every state. I could rattle off a name of somebody you could talk to that's doing this stuff. It's totally possible. And it's possible even within this financially hostile environment to primary care. The fact is, though, that most people who've been able to accomplish it have done it to the detriment of their personal health and the health of their business, which is unfair. Primary care ultimately held its social contract with the public. They put their interests first. They took care of them during the pandemic. They switched to telehealth, for which they had no funding. They continued to see them, even though they had no protection. They continued to take care of them, even though there was no vaccine. It's time for us to realize that they stood up for us, and we have to stand up for them.
So Rebecca, the distinction you're probably making, if I hear you right, is, actually it's important to know, are patients getting screened for colon cancer, or are people with hypertension having their blood pressure, is their blood pressure controlled? Those are clinical measures. They should guide quality improvement, but we need to be much clearer about distinguishing them from an accountability measure, which would be a more holistic one in primary care. Is that a fair?
That's right. Primary care, our latest research shows that on average, primary care deals with over 600 issues. And you can't point 600 measures at them. The sum of people's diseases and conditions does not equal the sum of their being. Primary care takes care of human beings, not bags of symptoms. And so we need to figure out how to measure them appropriately, aligned with the purpose and function of primary care, which is how they live and how they steward their health, not just how they get sick and die.
All right. So I'm hearing and some questions in the audience. So really systems need to support clinical improvement, not hold primary care totally responsible for that, and really need to think about a more holistic way of really saying, this is what we expect of you in primary care to meet.
Right. What we unfortunately do now with measures is we adjust. So we don't want primary care, because measures are connected to payment. We don't want primary care to suffer if their patients are sick. So whatever measures we have, we adjust them for whatever variables are encountered so that everybody can look okay. What that does is it completely erodes any clear vision of the health of the population. And it completely undermines any ability of a measure to actually reflect to what level should we aspire in treating these people. If we separate that connection, then we can understand people enter primary care when they're not feeling well, usually. So we don't grade them badly if somebody is sick. We grade them based on what kind of healing they provided.
All right, let's close. And I'm looking at, again, some of the questions coming in. Let's close. Let's add the wild card for our last item for this discussion. Jack, you touched on it, and somebody in the audience picked up a little bit on when you mentioned the Community Health Index. Measures for risk adjustment. You all didn't explicitly address this, but it starts to come up once you get into, well, what's the role of social measures and social risk? And should we pay more attention to that and not just disease-based risk adjustment? So do you all, anybody here on the panel, want to weigh into that one, whether it's the accountability measure, Rebecca, other ones for primary care spend? How do we think about social risk and measuring that among populations served in some of this measurement?
I'll jump in.
Oh, go ahead.
Sorry, Jack. And then I'll hand off the baton to Jack. He'll be better than I am anyway. I'll jump in and say that we absolutely need to measure social risk. If we don't measure it, then we can't respond to it. It remains hidden. It does not have to be the clinician who's the data collector for that. There are lots of different ways to collect that information. Clinicians do need to be aware of and act on that knowledge, but they also should not be held accountable for eliminating social inequities. That's not their job. Their job is to be aware of social inequities and to mediate them such that they don't become health inequities. So we need awareness to do that, but we need not penalize people for the inequities that are systemic in our society.
So I agree with Dr. X, and I would just say, you know, this is the sort of balance between hot spotting and cold spotting. Hot spotting being people who have high utilization of needs, they have multiple chronic conditions, they have deteriorated social determinants of health. But then there's the cold spotting, which says people live in the context of a community, and it's rare to have a single person with a disintegrated social determinant of health underpinning or foundation. Social determinants of health are regional and community-wide, and everyone in that community has some suffering from deteriorated social and disintegrated social determinants of health. And so while I think measuring individual risk is important, I think it's also crucial to understand the community and the infrastructure from which those people derive, and where they reside and where they live and where they work and where they do the 99% of their time that is not in the exam room or the practice. And so I think a hybrid model of individual risk adjustment with a community risk adjustment may give voice to both helping people address the individual things, which is what, you know, a primary care practice and in the exam room is about, helping that individual patient and their family, but also the opportunity to link what happens in the exam room with the broader community, the public health, the social and community organizations that we've heard from others. So I think there's a need to do a little of both.
Chris, you have 30 to 40 seconds to bring this on home. You want to weigh in on this?
Well, I'm challenged because I've been focused on the money. I think that the money is a prerequisite for making this stuff happen, frankly, and that's why Milbank focuses on this. We cannot get to the good things that Becca and Jack is talking about if we don't reorient the money and face the fundamental misallocation. And that's why it's not by accident that the first piece that the NASEM recommendations, the first action is payment. And everything flows from that. We can tie ourselves in knots about the mechanics, as Jack and I did, and there's been a lot of discussion in the chat around what means downside risk. But we got to get more money flowing to primary care to get the stuff that Jack and Becca are advocating for.
All right, well, I'll close. Then I get my editorial comment to end, which, yeah, wouldn't it be it would be a different day in the United States of America if we actually had money, more money in healthcare going to those people with the greatest social needs that have the greatest health inequities, rather than the converse, which seems to still be the American way. I think we're going to pause here for a few-minute break before we reconvene at the hour for the next panel. Is that right? Should I turn it back to you, Bob?
Oh, that's correct. We'll see you all back at noon sharp.
Welcome, everyone. Welcome back after your long 3-minute break, and welcome to our last panel. Welcome to our last panel for today. My name is Melinda Abrams. I am the Executive Vice President for Programs at the Commonwealth Fund, which is a national foundation that seeks to promote a high-performing health system. The first panel that you heard this morning outlined what primary care can and should look like in terms of operations and teams and services. The next one focused on, or the last one, focused on how we measure primary care to ensure its value for patients, families, clinicians, taxpayers. The goal of this panel is to outline innovations that the federal government could consider to strengthen primary health care. The innovations range from improvements in payment, which the last panel touched on, as well as improvements in our investment in the infrastructure to ensure equitable access to high quality, innovative primary health care, as well as innovations in how we plan and train the workforce to deliver primary care as a team and in a way that is integrated with the community. We have 4 distinguished panelists to help us with the discussion. First, we'll hear from Bob Berenson. Dr. Berenson is an internist, and he is an Institute Fellow at the Urban Institute. He's former CMS Director of Medicare Payment Policy and Contracting with Private Plans, and former Vice Chair of MedPAC. Then we'll hear from Louise Cohen. Ms. Cohen is the CEO of Primary Care Development Corporation, not-for-profit CDFI, with a mission of advancing health equity by increasing access to primary care through capital investment, training, technical assistance, and policy advocacy. Third, we will hear from Polly Pittman. Dr. Pittman is the Fitzhugh-Mullen Professor of Health Workforce Equity at the Milken Institute School of Public Health at George Washington University. Then our fourth speaker is Margaret Flinter. Dr. Flinter serves as the Senior Vice President and Clinical Director of the Community Health Center, Inc. and its Weitzman Institute, and is a family nurse practitioner of more than 40 years. Each speaker will have 7 minutes, and then we will open it up for Q&A. First, I'll turn it over to Bob. Go ahead, Bob.
And normally I'm on mute and forget to turn it off, but this time I didn't go on mute, and there's my slides. So in my 7 minutes, I'm going to talk, I was asked to talk mostly about the hybrid payment model that is part of the one of the prominent proposals of the NASM report on supporting primary care. And if there's any time in the Q's and A's or discussion, I can talk a little bit about their other proposal, other major proposal, which was about how the fees in the Medicare physician fee schedule are determined and how they can be improved. So go to the next slide, please. Back in the 90s was another time when there was a lot of action around paying for primary care. And, you know, those were the days of the gatekeepers, lock-ins, capitation was sort of on the ascendancy. And in the retrospect of the managed care backlash and all, Jamie Robinson, who's a professor at Berkeley School of Public Health, wrote a great article in Millbank Quarterly in which he said there are many ways for paying physicians. Some are good and some are bad. The three worst are fee-for-service, capitation, and salary. And he goes on to admittedly caricature these payment models because all payment models, in my view, have strengths and weaknesses. But if you could go to the next slide, he concluded that adopting blended payments can mitigate serious deficiencies in the pure payment methods, pure fee-for-service or pure capitation. And so the NASM report does call for a hybrid payment model for primary care, relying on experience, if not striking success, but lessons learned from the various CMMI demos. Some proponents of, or some, well, let's say proponents or opponents of fee-for-service go all the way to argue for pretty much total primary care capitation, almost total. But in my view, they minimize the concerns that arose in the 80s and 90s. Now, it is possible that the recent adoption of risk adjustment technologies and quality measurement, although we just heard in the previous panel that quality measurement often is more burdensome than helpful, can address concerns about stinting on care and risk selection, but how it works with a with a pure primary care capitation model has not really been demonstrated yet. And I would point out right here that capitation, or per person per month payment, per member per month payment, per beneficiary per month payment, depending on what context you're in, is very different. The dynamics of it are very different if it applied to a large group, say an ACO or a multi-specialty group practice, than it is for individual physicians. So I'm now going to be talking about just primary care payment to individual clinicians and presumably with teams that surrounds that individual clinician. So the NASM report supports the views that a hybrid payment model offers balanced incentives and the pure models. And the question is, how do you get there from here? Now, this is work that I'm now doing with support from the Commonwealth Fund. And we're looking at whether there need to be more demos, which is what's happened for the last 8 or 9 years, or whether we're ready to put a hybrid payment model into the Medicare physician fee schedule and presumably then ideally adopted by private payers and Medicaid programs. And it's unclear from a statutory basis whether CMS actually has the authority to implement this through rulemaking. There is precedent within the Medicare physician fee schedule for bundled payments. Maternity payments include an assumption of 9 months worth of care. It's a single payment. There are 10 and 90-day global payments that accompany procedures with the assumption that the physicians will do a certain number of visits within that global payment, but without fee-for-service reimbursement for those particular services. There's even a capitation payment for renal physicians supervising ESRD dialysis. So there are precedents, and it's possible, but not conclusive, that CMS could proceed through rulemaking. Another possibility is the Medicare Shared Savings Program, which is, better known to some as the ACO program in the traditional Medicare program. There's statutory flexibility for adopting new payment models, and it's potential that the idea of a hybrid payment model could be adopted within MSSP to get started, while legislation, if necessary, could be developed to expand that to all physicians, all primary care physicians. Next slide, please. I just want to make a couple of points about telehealth, and this is the one area that I personally had disagreement with this excellent report that the NASM committee came up with. And that is, I think there's a fundamental mismatch between financing most telehealth and fee-for-service. I've actually been a defender of fee-for-service for some kinds of services, but not for telehealth. They're typically high-frequency, low-price services for which there's relatively high billing costs. In some cases, the payment for telehealth would be less. Would be less than the billing costs for submitting for that payment. And if you add in then having to collect from patients their cost sharing, it becomes really untenable to pay that through a fee schedule. Coding for telehealth is fairly arbitrary and ever changing as communication technology changes. And the clear example is what's now being called audio only. When I was practicing, we used to call it the telephone. But the impulse to say that we're going to treat phone calls with patients to talk about clinical issues somehow fundamentally differently than if there's a video attached to it is arbitrary. Phones can be just as effective in many situations, not all situations, but because of the concerns about spending, it's likely there would be some arbitrary limits on audio only. And ultimately, because of reduced patient time costs and the relative inconvenience of office visits compared to simply being on a video call with a clinician during a lunch break, even if the volume hasn't dramatically risen so far, I'm assuming that over time it would become a major constraint, and then there would be arbitrary limits on what would or would not be covered through fee-for-service. The point is that the policy desire to support telehealth robustly, but at an acceptable cost, implies the need for a hybrid payment model, in essence, to make a virtue of necessity. To cover telehealth, we need to move expeditiously to a hybrid payment model. And I would argue that permanent pay parity, as many groups want, could set back prospects for alternative payment models for a long period of time. If not for telehealth, when would one move to a hybrid payment model? And the last slide, if you could move to that. I'm not going to go through this in detail, but the point is that the hybrid payment model has numerous design features You heard in the previous panel that there's an issue about whether primary care docs should be accountable for total cost of care. That's just one of the examples I provided. This needs to be worked through, but it can be worked through. Despite the need to find a consensus on these and other design features, a primary care hybrid model can be adopted. And given the nearly 10-year history with CMMI demos and prior history in HMOs where we've learned some things, but finally, this payment model is alive and well in a number of European countries. There is experience in how to do it. I think it's time, and we just need a commitment to get it done. Thank you.
Thank you, Bob. Appreciate it. And now we'll move on to Louise Cohen. Louise?
Hey, thanks very much to the Office of the Assistant Secretary of Health and to NASM and to all the other panelists for this exciting conversation about how to strengthen primary care. I have a slide deck. We can move to the next slide. Our organization is different from, I think, everyone else who's participating here. We have a unique perspective. We are a community development financial institution. We are US Treasury certified. We aggregate capital and on-lend it to safety net providers. Next slide. Our goal here is to on-lend for expansion, for renovation, for new sites, to improve services, to integrate care, to support quality improvement and financial sustainability of a whole variety of practices, and to advocate to achieve health equity. So we sit at the intersection of primary care, public health, and economic development. Next slide, please. And you can see that our metrics include how much we've leveraged in low-income communities, how many jobs we've helped create. And I think that's a little bit different sometimes from some of the primary care metrics. Next slide. You know as well as I do that the primary care ecosystem is varied, and we think independent providers are essential, and they're especially important in rural communities and low-income communities of color, in communities that serve specific language groups and so forth. But they have limited access to capital, which is one of the things I want to focus on here. Banks often have a local relationship with next slide, with a practice. But banks don't often understand how primary care works. And so we had, for example, a borrower who was interested and asked a local bank for a loan, and the bank said, great, you can borrow $2 million if you have $2 million in collateral. And that just doesn't seem to us to be kind of the way in which we know that primary care needs to be resourced. If you go to the next slide, we also believe that federally qualified health centers are critical in the safety net and actually for building economic community wealth, particularly in low-income communities of color and rural communities. They generate $55 billion in total economic activity every year. They are really, many of them are small businesses, but because they're not for profit, they're not eligible for capital through the Small Business Administration. And again, banks don't really understand how healthcare works, and so they don't really understand the model, and therefore have been reluctant to lend to federally qualified health centers. Next, I'm going to slip through some of the next of the slides because they really were covered by everyone else. So I would say here that primary care practices have to go a lot of different places for the resources needed to help them, and there's a whole industry of helpers. We're included in that to help practices get capital, improve quality, a whole variety of things. And we think that's one of the things the federal government should pay attention to, is this very fractured web of resources. So let's skip through the next couple slides because next slide and the next slide, because I think they were really covered very well by the previous, the previous folks. Chris talked a lot about the need for primary care spending, measurement, and improvement. The next slide, there's been a lot of conversation about social determinants of health. So I want to rest on, keep going, one more slide. I want to rest, one more. I want to rest on this right here. So one of the things that we know is true is that primary care practices need access to capital. And what we also know is that there is a huge diversity of federal programs and state programs designed to provide some amount of capital to these organizations. But it is, again, a fractured web of resources. It's insufficient. So there are about 1,200 community development financial institutions in this country. About 23 of them lend to healthcare entities. And between 1993 and the year 2020, CDFIs provided about 2.9, almost $3 billion to safety net providers for capital improvements, renovations, new sites, et cetera. But this is, although it's a large number in some ways, 1,200 loans in almost every state, it's barely scratching the surface. And I want to point out that in 2021 alone, private equity provided $22 billion. So quite a significant increase in healthcare financing, the majority of which is actually does not go to the safety net. And we know that even just among primary federally qualified health centers, there's an estimated $8 to $10 billion in capital financing needs for existing federally qualified health centers. And if we want to do what I think is absolutely necessary, which is double the number of federally qualified health centers that are providing primary care in this country, something that was done under the George W. Bush administration. He doubled the number of health centers. Under the ACA, another doubling. And if we want to go back and really address the issue of primary care deserts and inability to, particularly in the safety net, to provide adequate services, we really are going to need, as one mechanism to provide primary care, to really think about federally qualified health centers. And what the federal government can do, which I think is really important here, is they can coordinate and collaborate across the various funding streams for primary care. We can measure the amount of funding actually going to primary care compared to other areas. And this, I would say, we're woefully under investing in primary care through, even though there's a lot of money, it seems a lot of money coming through all of these various funding streams, it really is inadequate to the task. We need public-private partnerships. So for every, say, $1 million in infrastructure that comes through the federal government, we should really expect the private sector, through banks and community development financial institutions, to add another $1 million. So there really needs to be a way to leverage the private dollars out there, because I think that it's not only a government responsibility, but it is a private sector responsibility. And I think there is opportunity out there, and we can, in fact, provide the capital necessary if we actually sort of aggregated it in a different way and allowed primary care practices, whether they are independent practices, federally qualified health centers, and even safety net institutions like rural access hospitals and urban public health hospitals, to access capital at a very low interest rate for sort of a long period of time, and not expecting a return that private equity capital expects from our institutions. So I think that's a somewhat different perspective on some of the needs of primary care. I agree with what the other panelists have said about the other kinds of needs that primary care has and the importance of measurement. And I'm looking forward to continuing this conversation.
Great. Thank you so much, Louise. Now I'm going to turn it over to Dr. Pittman.
Thanks so much. I too have slides that I'm hoping are coming up. There they are. So I wanted to sort of look at these same issues through a workforce lens, particularly through what we call health workforce equity, which is a concept that I'll explain in a sec. Of course, what we want to kind of essentially do a run through of innovations for primary care. What I'm going to try to do is sort of identify actions that Congress can take, actions that CMS can take, actions that HRSA can take that might even be sort of simple tweaks, although undoubtedly there are a lot of vested interests behind each of these policies, and then some of the state level actions. So if you could stay on this, I just want to sort of define this concept of health workforce equity. We define it as a diverse health workforce that has the competencies, which essentially speaks to the education and training, the opportunities, which speaks to some of the system level constraints that the workforce faces, and the courage, which speaks to the agency or lack thereof that the workforce has in regard to change, to ensure that everyone has a fair opportunity to attain their full health potential, in other words, health equity. So it's health workforce not for as an end in and of itself exclusively, but as an end in and of itself that also has an impact on health equity. Next slide. So the way we think about this is 6 interrelated domains. And often people think about workforce in terms of sort of one of these domains. And I would say that it's really important to think about them as a set and how they interact with each other. So the first domain is who enters the workforce. That's largely around diversity, how they're educated and trained, which is what many people think about when they think about workforce, where and what they practice, so geography and specialty, whom they serve, which I think is an understudied area of health workforce, including whether they accept Medicaid patients, the uninsured, those with the most complex comorbidities, et cetera. How they practice, which is sort of a big bolus here, but practice patterns regarding teams and care coordination and who's in those teams and whether they address the social determinants, et cetera. And then under what working conditions, specifically sort of compensation and occupational health issues. Next slide. So I just want to run through these one by one. I think there are a couple of priors, though, when we think about workforce. First is that in this country, we have a problem, which is that there is essentially no brain trust for health workforce policy. We have a wonderful division of a Bureau of Health Workforce in HRSA and a program within the Bureau that looks at data analysis. But we don't have a policy analysis function the way we do for Medicare, for example, with MedPAC. And of course, that was written into the ACA and never funded. So a first problem is that we don't have that brain trust and that we need to fund the Health Workforce Commission. And candidly, I think it should be not only made up by people like me, but people who are not workforce experts and are payment experts and other kinds of experts, so that there can be a conversation across areas. The second sort of baseline problem is that we don't have a national registry of the healthcare workforce. And the National Provider Registry, Identifier, and PPS as it's called, is somewhat of a starting point. It needs modernization, it needs funding. They have race and ethnicity data, they don't make that available. And of course, there's the question of whether additional professions should be added to it that are not billing, because right now it is an NPI simply for billing. So these are 2 baseline things that I think would help everyone with a lot of workforce policy challenges. Next slide. So I don't want to spend too much time on the diversity issue. I think it's sort of well documented and relatively descriptive. We know why it's important. This is some work that our team has done that basically shows that across 10 professions, we're not doing so well. The first upper 2 figures are the incumbent workforce, and the lower 2 figures are the graduation 2019 specifically. So we think about that as, as the pipeline. And essentially, you can see that different professions are doing better or worse in terms of Black healthcare workers and Hispanic healthcare workers in this case, but a lot more needs to be done. And there are things like pipeline programs that need to be, of course, held accountable for outcomes, partnership with community colleges and the creation of stackable degrees, again, with accountability. And we've seen in particular for the advanced practice nurse, registered nurses, in particular NPs, a lot of success, which may be, we don't know, linked to employers helping to fund continued education, which seems to be a successful strategy. Next slide. So in terms of how folks are educated, we call this the social mission of health professions education, tipping our hat to the late Fitzhugh Mullen and the Beyond Flexner Alliance. A lot of these are sort of tweaks, and some of them are sort of bigger and are up against some vested interests that are pretty mighty. So a tweak here is that HRSA has this cap on indirects for training grants at 8%, which is, for those of you who live in the university world, know is peanuts, and leads to universities not valuing these programs. It doesn't seem like that would be too hard to change. Probably harder is this issue of the relative lack of funding for primary care research compared to the massive amount of funding that the NIH spends on specialty care. So, some adjustment in that regard. The medical schools themselves are educating essentially for GME match. We saw this year what looked like a bit of a drop in terms of US seniors' interest in primary care. We saw, a real problem in terms of matches with those specialties that are most favored by hospitals. So medical schools themselves need to reorient. their mentoring of students for different kinds of careers. And that includes things like that can be done on the government side in terms of increasing primary care training grants, including NPs and PAs in those grants, linking federal funding for GME to accountability measures. We have our own measures called the social mission metrics measures, but other workforce outcomes are really important as well. The GME system, we all know, is oriented to hyper-specialization and geographic maldistribution. It's a long-standing issue. There's been a NAM report on this. I think it's well understood. And then, of course, also well understood is the insufficient opportunities for community-based training for primary care. And although the ARPA provided quite a bit more funding for the teaching health centers, it's basically for 1 or 2 years, so we need permanent increased funding. We also need increased fundings for nurse practitioner, primary care residencies, and in my view, and it'd be interesting to hear what Margaret thinks about this, but some blending of some parts of those residencies, particularly if they're in the same sites or close by. Next slide. So the third domain is the distribution of the workforce, or maldistribution. In my view, restricted scope of practice, and not just for NPs, but also for PAs, pharmacists, PTs, behavioral health providers, for dental health providers as well, is obviously restricting access, and an easy move at this point, or maybe perhaps not so easy, but of course many states did allow expanded scope of practice during COVID, and making those waivers permanent might be a slightly more palatable route for those that have resisted change thus far. Of course, Medicare also had some interesting waivers that could be made permanent with this in regard to scope of practice. The HPSA designations, as we all know, have become ubiquitous, and there were many recommendations in years past of how to improve them, including NPs and PAs in the calculations. And we're particularly interested in including Medicaid acceptance, Medicaid participation by primary care providers as a measure as well. The National Health Service Corps has this program characteristic, which is that it only allows people to go into pre-existing sites and have a job offer in advance, which potentially restricts the impact of the program for areas where they're primary care deserts. So adjusting that program to allow for new jobs and new sites would be helpful. Next slide.
Dr. Pittman?
Mm-hmm.
I want to encourage you to wrap up quickly because we're running a little bit over, and I just want to make sure we have time for Q&A. Thank you. So not everybody accepts Medicaid patients. This can be measured. We've been measuring it. There's a lot more that CMS could do and states could do to make sure that not only in terms of payment and reducing administrative burdens, but in terms of tracking states' performance on this measure, I think would be helpful in terms of trying to expand the Medicaid health workforce. Next slide. Practice patterns. This is a bit of a long one, so I'll just speed through. I think it's largely around teams, although the unintended consequences of value-based payment are something that needs to be looked at carefully as well. But teams that payment for NPs and PAs may constrain the use of those professions. The issues around how difficult it has been for CHWs to bill, those could be made easier. RNs in primary care are still rare, except for in certain rural areas and HRSA programs. That's an area where more could be done as well. And then lastly, sort of the integration of the home care workforce with primary care teams. I think there's some opportunities for innovations that HRSA could lead in that regard. And the last domain is fair and safe working conditions. We have a large cadre of health workers that are paid very poorly, and we have a gigantic problem of burnout and moral injury. And there's some interesting experiments going on to reduce administrative burden in primary care that could be helpful in that regard. So I will end there and turn it back over to you, Melinda. Thank you so much. And now I will turn it over to Dr. Flinter. Margaret?
Great. Well, good morning, everybody. Thank you so much for having me. I want to thank Louise for putting up a great shot of one of our grand openings on her slides. I don't know if that was intentional or not, but it was a nice memory to see there. I know firsthand from years of clinical practice and research and leadership that high quality primary care is possible. It exists today, but as the NASM report notes, it's not what all people in all communities in the US experience today, and we're trying to change that. And I want to bring you greetings from all of us at the Community Health Center, Inc. and the Weizmann Institute, where we've been working for 50 years to make healthcare a right and not a privilege, from our neighborhood health centers to shelters, farms, and schools, and to solve problems through research and innovation in primary care. So I was asked to address 3 areas in my brief time allotted. 1, scaling the use of interprofessional team models. 2, how to scale e-consult models to improve specialty access in primary care. And 3, the need to coordinate HHS awards and initiatives. I think number 1 and 2 are going to get most of the time. There is good evidence for the positive impact of team-based care on clinical outcomes. Don't think we can dispute that, and it provides support for patients and support for the clinical team. And the good news is we have very well-established, well-evaluated, and replicable models of interprofessional team-based care already in place. Certainly found in many of the nation's federally qualified health centers, also in Veteran Affairs primary care practices, and as the LEAP project, Learning from Effective Ambulatory Practices, showed a few years ago. We found evidence, somewhat sporadic, but we found evidence for interprofessional team-based care in practices, rural and urban, large and small, private and public, around the country. I think there's 2 distinct elements to having a successful interprofessional team. One is the education and training of the individual members of the team to their specific role and discipline as part of their preparation for practice. But the other is the practice or the organization's definition and choreography, if you will, by policy, by procedure, by physical plant, and by practice of the function of the team as a whole. So I thought I'd offer up 3 models that my organization has developed or worked on and share it with you. 1, NEMA, National Institute of Medical Assistant Advancement, now an accredited school for medical assistants, founded with the specific intent of training MAs to a high-performing model of primary care, but doing it in partnership with FQHCs, now in 14 states, who themselves recruit students from their local communities. The didactic classroom component is done virtually for the whole cohort, the clinical training right from the start on a primary care team in the Medical Assistant Students Health Center. Very, very effective. 2, recruit new grad NPs for a 12-month intensive postgraduate NP residency training program in FQHCs and other settings, family, adult, pediatric, psychiatric, mental health NPs, and train them specifically in this model of integrated interprofessional team-based care. I really want to give a shout out again to Veteran Affairs and other health systems around the country that are doing that. We started the first one 15 years ago. There are about 240 of them around the country now. And 3, train the full pipeline of behavioral health providers, social workers, psychologists, psychiatrists, nurse practitioners, pre-licensure, post-licensure, peer level, who are able to manage the full range of care from children to adults that we see that we need today, including substance use disorder, whether that's opioids, alcohol, or cigarettes. And very importantly, when we speak of scaling team-based care, we have to do it at the level, not just of the clinical staff, but the level of the data, the technology, and leadership. Now, I think most primary care practices today engage in education and training of at least one kind of team member and maybe multiple team members. Not everybody has made it a religion like we have. But I suggest we all need to do more, including, as I said, behavioral health training in primary care. But they don't have to do it all at once. They can do it over time. I'm sure we started many years ago with one discipline. I think it was probably nurse practitioner students. But today we have behavioral health students and trainees at every level. We have nursing students at every level. We have chiropractic residents, pharmacy, medicine, dentistry. Everybody needs a home for their clinical training. But making them function as a team, fully integrated, is equally important. How they do that, beyond all the things the organization can perhaps do, is to provide formal coached training. And I want to give a shout out to HRSA for the Cooperative Agreement on Clinical Workforce Development that gives us an opportunity to offer organizations this kind of intensive coach learning collaborative with other health centers on implementing a model of team-based care. I know my time is short, so I want to move on to talking about e-consults. Totally different, but the same in that it really supports our patients our practices, our providers, and our organizations. What was once one of the most vexing challenges for primary care providers, I can attest to this, was access to a specialty consult when you needed it, particularly in settings with significant uninsured, underinsured, people who primarily speak other languages or are geographically isolated. And I think this has largely been addressed in concept, if not 100% in practice, through the development and the scaling of e-consults. I think many of you know this was originally developed by Mitch Katz out in San Francisco, further refined and studied in multiple studies, including by our Weitzman Institute, with consistent findings of eliminating delays, if indeed you could get one, findings of good quality, of safety, of reduced overall total costs, and with a need for follow-up face-to-face or synchronous specialist patient consultation less than 20% of the time for most of the specialty areas. Now a covered service by Medicaid in many states and Medicaid managed care plans. We have a group, CECN, that's devoted to advancing this work and helping programs start an e-consult program, and it's been transformational. But I have to stress, we can't do this by adding more burden to the primary care team. The system of creating and sending and returning an e-consult has to be smooth and efficient and able to be done by other than members of the clinical team. They need technical assistance in how to effectively use an e-consult service. So in my remaining probably now just 1 minute, let me say that each of these initiatives can be taken to scale and more widely implemented across multiple systems as part of a national strategy towards this implementation of high quality primary care. Loans and scholarships for individuals from underrepresented communities would provide the opportunity for MAs, and probably CHWs and peer counselors to train in the NEMA model. BHW now funds 36 postgraduate NP residency training programs, but there's demand for more. We could designate specific funding for postgraduate clinical psychology residencies and FQHCs and other organizations that demonstrate they have an integrated team-based model. We can make sure that no nursing student graduates from their university without an experience in primary care, which doesn't happen today, so they can see firsthand the impact of high quality primary care nursing on patients and outcomes. And as I said, e-consults need to be a covered service by public and private payers. I've got some more information for you in the material that I provided that's available to everybody. So I'm going to stop here to thank the people who have supported the development of primary care to this point. We all know we can do much more, whether it's in payment models or model design. And I look forward to the questions. Thanks so much.
Thank you, Margaret. Thank you all. Thanks to all the speakers. Now, in our last 15 minutes for this session, we're going to just run through some quick Q&A. I'm going to start, and I'm encouraging everybody to please add questions into the Q&A in the chat feature. So Chris Kohler ended the last session by saying, you know, he always starts with the money and talked about how the NASM report focused on payment. So Bob, you, in your initial remarks, you know, you really focused on how we pay. And, but in the chat, and then it was also touched on by a number of the speakers, we also heard about a need for how much we pay. So the NASM report does touch on the Medicare physician fee schedule. And I guess I was wondering if there were examples that you could touch on about how these fees are potentially distorted, the role of the primary care versus the proceduralists. And if you could just talk about that for a second, and then others may want to as well.
Yeah, I'd be happy to. I mean, the initial question that some might ask, I asked it myself, is if primary care docs have their own special payment system, why does the NASM report care about the overall physician fee schedule? There's a couple of good general reasons. Is because the fee schedule is broken in many ways, and it affects how physicians of all kinds spend their time and what they do. But with specific reference to primary care, I'd make just a couple of points. One is that there's this sort of mantra that fee-for-service is a problem because it pays for every service that a clinician does or refers for, regardless of the appropriateness or the quality of how they produce the service. And in fact, that's not true. There's a substantial literature base that shows that for primary care physicians, and this is prior to electronic health records becoming so dominant, 25% of what physicians did during a practice day were not paid through fee schedules. It was just money that they just had to absorb. And so to make up for past deficits, there needs to be some payment for primary care. We need to sort of, with some basic research, find out what the burden is on specialists who provide services that are not paid for the fee schedule, but I would assume it's much less than primary care. Number two, there is substantial, what the word we're using these days is distortion in the fees. And by distortion, I mean payment in relationship to the relative resources that go into producing the service. And it's pretty well documented that many procedures, imaging, other tests are overpaid. Time spent with patients is underpaid. And by correcting that, and it can be done, and we have ways of doing it, we would free up some money to add to the package for primary care. And finally, the current Medicare fee schedule doesn't allow CMS to consider policy objectives in establishing fees. So MedPAC over many years has basically said that we have a workforce problem of maldistribution of specialists. We need to increase payment for primary care physicians, but CMS is obligated to follow a payment model that was developed 35 years ago and unchanged ever since. Seems to me that paying to achieve the policy goal of assuring access for Medicare beneficiaries would be something that should happen. Occasionally, Congress passes a law like in the ACA that gives a little bonus for primary care. It ends after 5 years and isn't continued and didn't have the impact it might have had because docs knew it wasn't going to be sustained. So there's a number of reasons to improve the Medicare physician fee schedule, as well as moving to a payment model. The hybrid payment model assumes there's going to be increased revenues for primary care practices.
Thank you. A number of you touched on workforce training and training, whether it was resources for training, the supply issues, the sites for training. I guess what I would like a number of you, we can actually maybe would actually start with Margaret, with Dr. Dr. Flinter, but also, then Dr. Pittman and Louise, I think you'll have quite a bit to say here as well. So when we talk about the workforce, we often immediately focus on HRSA and doctors, and really important. But I guess I would really like to hear from you, both your experience on the ground and then thinking about it nationally. If you could talk about like the number and breadth of agencies at the federal level that touch on training and workforce, and therefore why is there a need for greater coordination at the federal level, as opposed to keeping it all just, or just focusing exclusively on HRSA or only on doctors. So Margaret, I'm going to start with you as a teaching health center site.
Yeah, I'm pretty sure nobody would ever accuse me of just focusing on doctors when it comes to workforce training. So I'll take myself out of that group and try and answer the question maybe in three parts. One, if not all innovation and training requires funding at all, but taking it to scale does. And that's something we're very aware of. So we're a lot about building models of training that work, like the NEMA program, like the nurse practitioner residency program, but then taking it to scale, and somebody needs to fund it. And there's probably a role for private foundations as well, although they're not as reliable over time. In terms of other organizations, certainly the Department of Labor, if I'm calling it correctly, has provided some interesting funding, I think, around workforce development, particularly of the more certificate level programs like community health workers. And I think that's very positive. Anytime we can get some synergies there. Veteran Affairs certainly has made a huge investment. They always have had a huge investment, but I've been very impressed that Veteran Affairs has been very responsive to changing needs. They really led with the first psychiatric mental health NP programs as a strategy to make sure that they could better meet the needs of their veterans. Education certainly has a role to play. The Department of Education has a role to play in terms of who they accredit and how they accredit, and that accreditation being part of what allows students to have loans. So I think it's a multi-pronged strategy, and any group that is able to help, I think we should be looking at in terms of taking it to scale. In terms of physicians, I would just say, GME is its own world that Dr. Berenson and others probably know better than me. HRSA kind of had to create the teaching health center program because you just couldn't get physician residencies and dentist residencies in health centers without creating a new line. And I know the NASM report addresses some GME redesign issues as well. And I think that's a fruitful area to look at.
Great. I don't know if I could go on to another question, or if Dr. Pittman,
I would just add 2 other agencies. Obviously, CMS has a gigantic role through payment policy in determining how teams are conformed. The issue of what you're allowed to bill for and what you can't bill for is directly related to the conformation of teams. So when you think about education and training for the non-physician workforce, it's largely dependent on the demand for those workers, and that's largely dependent on payment. So more coordination with payment and how workforce people are thinking about new cadres of workers is really important. And then, of course, the Department of Education is critical. They did a lot in the Obama administration around these report cards. For nursing in particular, it would have been very helpful to have report cards that you could disaggregate by profession. They lump together all the health professions that are not physicians, and so you can't really see what the performance is, and there's some big issues, in particular, frankly, around the for-profit nursing schools that need to be teased out, and they've got the data, but they don't make it available.
Thank you so much. I guess I just wanted to point out, just for the audience in particular, just that there's the GME piece of this training, which is both Medicare and Medicaid. There's HRSA, there's the VA. So again, this need for, if we are going to try to be planful, deliberate, and coordinated, we really need to think across multiple agencies. Similarly, and Louise, I'm going to turn to you on this one. Healthcare in the United States is a public-private partnership, right? A lot of people are covered through Medicare, Medicaid, which is publicly financed, but the practices are, or the sites of care are, private nonprofits or not. And a lot of people refer to primary care as a cottage industry. I guess part of what I'm thinking through is your work at PCDC and all the technical assistance that you provide. If you could talk a little bit about, like, what does it take and why is it so hard for the adoption and the innovation and kind of the embracing of either new payment models or delivery models? I know there's a lot of innovation, but why is it so hard? And why, again, would we need kind of broad-based federal coordination and support to enable this kind of adoption?
Well, I think it's an interesting question. And I would say, I'd be interested to hear what other people have to say, but I think one of the things is that primary care providers, first of all, are required to do an enormous amount. Not only treat the patients that walk in the door, take care of the patients in their panel that don't walk in the door, as someone mentioned earlier. They have enormous number of measures. They have between 7 and 15 insurers that they're all responding to. And then there's all these new innovative things that everyone wants them to do, including important things like address social determinants of health and other issues. But when you're a primary care provider and you're stacking up patients all day long, the question about how do you address someone's housing is actually it's a real one. One of the reasons why the federally qualified health center model is important and interesting is because this concept of a threshold visit, let's put aside for a minute that they have limited numbers of providers that a threshold visit relates to, in other words, primarily physician. But when someone walks in the door, one of the things that the payment of a federally qualified health center is supposed to be directing to is a whole variety of services. There are social workers, there are community health workers, there are patient navigators, there are nurses, there are dietitians, folks who can help you with a whole variety of issues. And so that they become theoretically one-stop shopping. When we tie all that to a visit, sometimes the downside is that then we want to say, well, that should be 2 or 3 visits, and sort of figure out how much money is available for a visit like that. and FQHCs will tell you that that payment isn't sufficient for all of those things. When you go to an independent practice, they're not getting a quarter of what a federally qualified health center might be getting, maybe a half, but they're still struggling to sort of do all those things as well, but they really don't have the resources. So I think one of the issues is to think about this much more systematically, which we don't. And so we don't think of the primary care system as an ecosystem with a whole variety of different flavors. And how do we think about the kinds of things that people need and how to get them to them? What we really think about is our payment model is designed primarily for sort of a visit and what that entails. I think that there's opportunities going forward as we think about different models of care, and not to say that one is necessarily completely better than the others. All of them have their strengths. And all of them should be relating to patient choice, right? People should decide what kind of primary care provider they want to go to, whether they're at a hospital ambulatory setting or whether they're in a health center. But I think that those are the things that the payment system and what the person's sort of expectations are really align very much. So if I walked into any health center, would I get all of those services? So I think that there's a lot of work that can be done to align those things. But I do think that, as Margaret said, it's about going to scale. You can do any number of pilot programs. You can innovate on anything. And I can tell you that all of your patients will get better in those programs. Going to scale and paying for going to scale is the thing that we do not do well in this country. And that's true whether it's CMS, HRSA, the Department of Education, any federal agency. And I would argue that is the fundamental challenge that the federal government has in front of it today.
Thank you,
Can
Louise.
I make a comment?
Sure. But quickly, because we're running out of time. Thanks, Bob.
I'll try to do it real quick. What Louise, one of the things she mentioned is sort of the small independent practices. The Medicare physician fee schedule was set up 35 years ago, was created, did not distinguish between independent practices and employed practices. Almost everybody was independent in those days. It continues to pay what's called indirect practice expenses, the same level to physicians who are employed in hospitals, even though the hospital is providing the billing service, the heat and utilities, all of those indirect expenses, they are dramatically paying too much for the hospital-based physicians and underpaying the independent physicians. And that can be corrected and needs to be corrected. It's another reason to deal with the fee schedule.
So we are almost out of time, but I wanted to just ask one more question that's from, there are now all of a sudden all these questions in the chat at the last minute. But Ann Greiner asks that the NASM report, calls upon changes in the payment model that would pay teams for outcomes, not individuals for services. But how would that work in practice in terms of distributing the money across the team? Who wants to start? Margaret, do you want to start?
In 1 minute or less?
Yes, actually, yes.
I think this is part of the work that has to be done by the groups that have organized to now carry out the next phase of the NASM report, which is how do we actually do this? I don't think paying just for outcomes will carry us all the way, although I am a big believer in value-based payments for putting your focus on what you're trying to change. And I think we have very good evidence, but that's unpredictable. And you can't provide a service unpredictably in a community. You commit, you have a platter of services, you're providing those services. So I think that the idea of paying teams is something that is another way of saying we're paying for really excellent primary care. How we get people to change that formula, I think is another story. Medicaid payments, the FQHC world did not make it a requirement for states to adjust those payments every year. Our last major adjustment was about 19 years ago. That just doesn't work. MEI indexes don't get there. So that I think is huge. I also, I have to say a little bit parenthetically, but I've watched with some astonishment at how Medicare Advantage plans pay and the range of services that they will pay to get the outcomes that they seek. And I think, gosh, one of my 7-year-olds living in an impoverished family with all sorts of social risk and deficits could get the benefit of all those wraparound services. Wouldn't that be a great thing on the theory that somewhere it was reducing costs. Maybe those costs are 20 years down the road with somebody who's successfully completed their education and is working.
Right.
So this is a big conversation to have. Look forward to having it with everybody.
Thank you very much, all of you, and to everyone in the audience. And now I'm going to pass it off to Dr. Judith Steinberg for the closing remarks to end day one. Thanks.
Okay. Thank you, Melinda. So I'm Judith Steinberg. I'm Senior Advisor to the Assistant Secretary for Health, and I'm leading the initiative to strengthen primary health care. So first, I'd like to start by thanking the speakers for their outstanding presentations and discussion. And also thanks to our audience members for your very active engagement and the key questions that you posed. And of course, thanks to NASEM for hosting this important webinar. So we just heard a whole lot of information in a short period of time. So with my closing remarks, I'll provide some highlights of the webinar and basically some key takeaways. We began by setting the stage, hearing about the NASEM Primary Care Report and the HHS initiative to strengthen primary health care. And today and tomorrow's webinars were really designed to inform the development of the HHS plan and the implementation of the NASEM plan's recommended actions. So we began where we should begin. What do people, family, and communities need and desire from primary health care? Key messages are the desire for a respectful, trusting, and ongoing relationship with their primary care provider and team, attention to who they are and the context in which they live and work, and their goals, what matters to them. Primary care should be advised by the patients and communities served and should work in partnership with them. The examples that Dr. Mishner gave about listening and working with communities to improve health and health care are just so instructive. Then we heard about a model, City Block Health, that embodies and operationalizes these principles. I love this summary. To engender trust, primary care should listen and do something. Change always begins with measurement. You can't change what you don't measure. So we heard from measurement experts on how to measure primary health care. And here are some key messages. Primary care measurement should be streamlined and should be used to hold the system accountable for ensuring the resources needed to achieve the goal. I think the distinction between clinical measures, such as screenings and blood pressure control, and performance measures, whether primary care is delivering or able to deliver on its promise, was also very instructive. We heard alarming workforce data trends during the COVID-19 pandemic and the challenges of measuring the full complement of activities of primary health care, not just those that are billable. States are beginning to track primary care investment and set targets for increasing that investment. A key message was the need to standardize the definition of primary care and its measurement. Then we moved on to innovations that lend detail to NASEM's report's recommended actions. Innovations on how we pay for primary care, how a hybrid payment model might be implemented through the current CMS physician fee schedule process and/or through the shared savings program, and how telehealth services are really best paid for through a hybrid payment model. We heard how primary care practices as small businesses have a need for upfront investment and capital financing in order to achieve the model that our plenary speakers had described. A message, the need to coordinate and measure federal funding for primary health care. Payment change is critical, but so is addressing the primary healthcare workforce. Key messages included the need to fund a National Health Workforce Commission on policy, suggestions on how to optimize government-funded workforce programs, such as training grants and the National Health Service Corps, and how to begin to change graduate medical education to better address our workforce shortages. And this begins again with measurement and accountability and coordination across federal and state funders. We also heard about how best to use the increased investment in primary care, new payment models, and government-funded programs by developing the skills and capacity of interprofessional teams and improving the coordination of generalists and specialists. and the need to bring these payment models and workforce programs to scale. That was a very important message. So in closing, let's consider these takeaways as we, as a collective, take action to strengthen primary health care for all people, families, and communities in our nation. And stay tuned for tomorrow's webinar when we'll hear about innovations in primary health care that are happening in states, territories, and tribal nations, and the importance of state and federal partnerships. Thank you all, and let's reconvene tomorrow, March 23rd at 10 a.m. Eastern. Have a great day.